The meeting will come to order. I'd like to welcome everyone to this meeting of the California Technology Assessment Forum, or CTAF. My name is Dan Elliott, and I'm the chair of CTAF. And to my right is Paul Heidenreich, who is vice chair. At this time, I'd like to introduce four new members of the CTAF panel: Ralph Brindis, cardiology; Luanda Grisette, cardiology; Joy Melnikov, family medicine; and Rena Fox, internal medicine. This today is a little bit different. We're actually having two sessions. We have two separate topics. The morning session will be on diabetes, the afternoon session on asthma. A couple of comments on CTAF. CTAF is a core program of ICER, and as such, reviews ICER-produced evidence-based reports on the effectiveness and value of healthcare services and provides a public venue for discussion among all stakeholders. CTAF's mission is to help patients, clinicians, insurers, and policymakers interpret and use evidence to improve the quality and value of healthcare. CTAF's vision is to create a future in which collaborative efforts to move evidence into action becomes the foundation for a more effective, efficient, and just healthcare system. I want to say a word about the conflict of interest policy. This policy is in detail in your packet. We ask all speakers, roundtable participants, and individuals making public comments at this meeting to disclose any relationships with industry or other potential conflicts of interest related to today's topic when they speak. All members of the CTAF panel have been asked to disclose conflicts of interest for this meeting, and none have been reported. At this time, I'd like to introduce our new program director, Matt Seidner. He's been a member of the ICER team since 2014 and has contributed to ICER reviews, including new treatments for hepatitis C, integration of behavioral health and primary care, and new interventions in the management of heart failure. So, Matt?
Thank you, Dan. I'd also like to welcome everyone in the room and on the webcast to the CTAF public meeting on insulin Degludec for the treatment of diabetes. Thank you all for joining us. I'd also like to thank our funders, the Blue Shield of California Foundation, the California Healthcare Foundation, and the Laura and John Arnold Foundation for supporting CTAF and ICER. As a brief reminder, please put your cell phones on vibrate, and should you need them, restrooms are outside and down the hall to the right. I'd like to briefly go over the agenda for the morning session. So we've convened the meeting at 9 a.m., following which we will have a presentation of the evidence and economic modeling by Drs. Jeff Tice and Rick Chapman. Following that, we'll have a brief public comment session, after which the CTAF panel will deliberate on the voting questions presented in your packets and vote on the key questions. Following the CTAF vote, we'll host a policy roundtable discussion, after which we will have a brief moment for reflections from the CTAF panel before breaking for lunch. Those of you who would like to download the meeting materials can access them at tinyurl.com/ctaf-degludec. And I would also like to introduce Dr. Jed Weisberg, who will set the stage for today's discussion. Dr. Weisberg is a gastroenterologist who joined ICER as a senior fellow in 2014. He had a 30-year career at Kaiser Permanente, most recently as Senior Vice President for Hospitals, Quality and Care Delivery Excellence, and has also been the Medical Director of Medicare Advantage, Cost, and Prescription Drug Plans. Jed?
Thanks, Matt. And Matt's done a wonderful job with his first meeting getting this all set up. Thank you again. For those of you who are new to ICER and CTAF reports, if you've read the report, you'll see that we have an executive summary and then a far more detailed description of how we reviewed the clinical studies, the strategy for our systematic reviews and analysis, coupled with a very clear model of economic value to the individual and to the healthcare system. Those analyses will be reported this morning, and as Dan indicated, we have two topics today. We're trying to increase American productivity, and we are doubling our output, so we hope to see value in the stock market later this evening. Our morning topic will be on a new insulin molecule, which is coming to market. Our afternoon topic will be on a new monoclonal for asthma. So both specialty pharmaceuticals in a way, though there'll be some important differences that are brought out. Some of our audience will shift between the morning and the afternoon. Some will stay, as is true of our clinical experts, but our panel members will stay the same. We have a very clear-cut approach, which is documented in our ICER website as to the methods for analysis and value analysis, and we will show how those come into play when we ask our panel to vote on the net health benefit, the care value that's accorded to individuals from the new health intervention, and then the analysis of the economic value at the individual level and at the health budget value, level. So we'll be going through that. Matt will be helping everybody with our voting. The voting is public. We'll be asking our panel members to record their impressions as they go through their thinking as to what constitutes their decision. It'll be a little bit like the exit polls we've been seeing in New Hampshire and Iowa, except not quite as bombastic, I expect. And then that will all be written up. Sonia, our newest program manager over there, will be helping us write up the results of today's meeting. All of that will be added to our draft report, which is on the website as of today, and will constitute our final report. We do have a few registered public commenters, both for the morning session and the afternoon session, and Matt, I believe there are only 2 each so far, so we'll be having plenty of time, the full 5 minutes for that allocation of our time. With that brief introduction, I think the idea was to say, why is diabetes important? Well, for people in this room, I think that's pretty much self-evident. However, as we heard from one of our clinical experts, and we'll hear a little bit later during the roundtable discussion, the arc of treatment and understanding of diabetes from the time of Banting and Best in the early 1900s until today has undergone quite an evolution. And it'll be our task today to weigh the incremental value of this new insulin molecule for the treatment of diabetics. Given the importance of diabetes societally, CTAF will also be looking at diabetes prevention programs at our next meeting. So we will try to package it all together, treatment and prevention over the course of the next quarter. And with that, I'd invite Jeff up to the panel to start our clinical evidence review.
Great, Jed. Thank you. So I'm Jeff Tice. This is the team, and I have no conflicts of interest to declare. As was alluded to, diabetes is a very common, a major problem in the United States. About 29 million Americans are affected, and 6 million are using insulin. So I would be thinking about this new insulin we're considering today. The vast majority of diabetics in the United States are type 2, the adult onset phenotype that's associated with insulin resistance, and about 5% are type 1 diabetics, those who have an autoimmune disease that destroys the body's ability to produce insulin. We've moved to more intensive management of diabetes over the past few decades with target pre-meal insulins in the 80 to 130 milligrams per deciliter range, and a target hemoglobin A1C, which looks at blood sugar levels over a 2 to 3 month period of less than 7%. Large randomized trials have shown that this leads to a decrease in what we call microvascular, small vessel complications of diabetes, in particular retinopathy leading to blindness, nephropathy leading to kidney failure, and neuropathy leading to loss of sensation in the feet, which is often a precursor to the dreaded amputations that many patients are worried about when they're first diagnosed. There is controversy around the effect on hypoglycemic events and death. Clearly, the tighter the control, the more often we see low blood sugars, hypoglycemic events, and they can certainly lead to seizure, coma, and death. In some of the recent trials of tight control, there's actually been an increase in heart attacks and death from cardiovascular disease. So there's a concern about being overly aggressive, and the thinking is that it's hypoglycemic events that trigger these cardiovascular events. Our definitions of hypoglycemia that are widely accepted for studies of diabetes come from the American Diabetes Association Working Group on Hypoglycemia. They're summarized here. Severe hypoglycemic events are events that require an outside person to administer some therapy to patients, so to deliver glucose, glucagon, or other forms of resuscitation. Confirmed hypoglycemic events may not have symptoms, but have a measured blood sugar level of less than 70 milligrams per deciliter. Those that occur at night are considered nocturnal hypoglycemia. And the ADA has indicated that therapies may be considered to offer a clinically significant improvement over other therapies if there's a 10 to 20% reduction in significant hypoglycemic events or a 30% reduction in total hypoglycemic events. With that, we'll turn to the drug that's the focus of the meeting this morning, insulin Degludec. It's a long-acting insulin. There are two forms, two different concentrations, U100 and 200, 200 being more concentrated. The half-life is approximately 24 hours, which allows for really once-a-day dosing with even some flexibility during the day as to when that's administered to achieve a steady-state level of this long-acting insulin. The FDA approved this formulation in September of last year, and the indication was to improve glucose control in adults with type 1 or type 2 diabetes. There are a number of other FDA-approved long-acting insulins, insulin Detmir, which is also known as Levemir, two forms of insulin glargine U100, Lantus and Basaglar, and recently a more concentrated formulation of insulin glargine U300, which is known as Toujeo. So our methods, we performed a systematic review following standard guidelines for systematic reviews. Our target population followed the FDA indication, so adults with type 1 or type 2 diabetes. The intervention was our drug of interest, insulin Degludec, and the comparator, we searched for any trials comparing insulin Degludec to a long-acting insulin. The outcomes of interest included the major outcomes associated with diabetes, so cardiovascular events, microvascular events, changes in hemoglobin A1C as a measure of glucose control, hypoglycemic events, and any other adverse events. There were 8 randomized trials identified. They are all industry-sponsored phase 3 trials comparing insulin Degludec to another long-acting insulin. 3 of them focused on patients with type 1 diabetes, and 4 with patients with type 2 diabetes who required just once-a-day basal insulin, and 1 in patients with type 2 diabetes who required both basal and bolus therapy. All of the trials followed the same basic design. They were all non-inferiority trials, so they were designed to produce similar levels of glycemic control, reductions in A1C, and baseline glucose levels. Specifically, they targeted morning fasting glucoses to be between 70 and 90 milligrams per deciliter in all of these trials. The long-acting insulin administration with Degludec was always in the evening. Insulin glargine, which was a comparator in 7 of the 8 trials, the FDA approval is to use it at any time during the day. So the trials allowed this to be left up to the discretion of the patient and their clinician. They could take it in the morning or the evening, but they needed to take it at the same time every day. Primary outcome, as noted, was hemoglobin A1C, and this was an equivalence outcome, so you never have exact equivalence. There's always a confidence interval around that, and the agreed upon threshold for equivalence was a difference, an upper bound of the difference of less than 0.4% on A1C. Secondary outcomes included the various hypoglycemic events. So let me see, do we have, I think I'll try and use the pointer here. If I can. Yep, I may be just advancing things, sorry. I don't know, maybe I can do it with this, yeah, okay. So I just want to orient you to this. These are the primary outcomes for change in hemoglobin A1C. The three trials in patients with type 1 diabetes are at the top, then the trials in patients with type 2 diabetes who required basal only, and finally the one trial with basal bolus. The comparator were in all of the trials except for one. Sorry about that, was insulin glargine U100, in fact, the Lantus version of that. And one of the trials in patients with type 1 diabetes, insulin Detmer was the comparator. And then if you focus on the last column, this represents the difference in the change in hemoglobin A1C. And it's a little hard to wrap your mind around it. It's the change in A1C seen with insulin Degludec minus the change seen with the comparator insulin. And rather than you trying to figure out the math, just trust me that if the number is negative, that means it favors insulin Degludec. If it's positive, it favors the comparator insulin. And you can see for the first two trials, it's negative, so there was nominally a greater reduction in A1C with insulin Degludec than with insulin glargine in the first trial and insulin Detmer in the other trial. The differences were not statistically significant, and importantly, the primary outcome, again, is equivalence, defined as the upper bound of the 95% confidence interval being less than 0.4%. And if you look down the column, in all 7 of the trials that reported these confidence intervals, they are all less than 0.4. So in all of the trials, insulin Degludec met the non-inferiority goal of the trial. So the conclusion in all cases was that insulin Degludec was non-inferior. In one of the trials, the third trial in patients with type 1 diabetes, the difference was actually statistically significant in favor of insulin glargine. And you see that in 6 of the 7 trials comparing Degludec to insulin glargine, there was a trend towards greater reduction in A1C with insulin glargine rather than insulin Degludec. The one trial, the fourth trial in type 2 patients with type 2 diabetes who received basal-only therapy, the confidence interval wasn't calculated for this comparison, but the difference was about the same as the Matthew trial and likely was statistically significant. That's why I bolded those two figures. All right. Let's turn to hypoglycemia now. So they were, in all trials, insulin Degludec was non-inferior by the pre-specified threshold. For hypoglycemia, there's a meta-analysis that was pre-specified also, and this was combined the 7 trials looking at insulin glargine versus insulin Degludec. For patients with type 1 diabetes, the first row of results, there were no significant differences. There was a strong trend that was borderline significance for nocturnal hypoglycemia, but it was not statistically significant. So for type 1 diabetes, no difference in total hypoglycemia, nocturnal hypoglycemia, or severe hypoglycemic events. For patients with type 2 diabetes receiving basal-only insulin, there was a significant reduction in total hypoglycemic events and nocturnal hypoglycemic events, about a 36% reduction in nocturnal hypoglycemic events. There was a report of a statistically significant reduction in severe hypoglycemic events in this meta-analysis, but they only reported actually the results from one of the 3 trials that reported severe hypoglycemic events. So I've highlighted that as being somewhat uncertain. It's not truly a meta-analysis of all the trials there. It just picked the one that had a significant difference. There's only one trial in patients with type 2 diabetes on basal bolus insulin, and the results are presented there. There was a reduction in both total and nocturnal hypoglycemic events, but not severe hypoglycemic events. With major adverse cardiovascular events, there's some concern. The drug was initially submitted to the FDA in 2012, and the FDA did not approve it at that time, primarily because of a concern about major adverse cardiovascular events. The numbers are given here. You see a 67% increase in major adverse cardiovascular events, strokes, heart attacks, death from cardiovascular disease, that was of borderline statistical significance, so a p-value less than 0.05, but a large number of heterogeneous trials combined, and there was concern that this may just be a chance event. That said, the FDA required a large randomized trial to be performed, so there have been over 7,000 patients randomized and followed over time. The trial should finish in September of this year. The results are not available, but interim data were presented to the FDA, and that's likely the basis of the approval of insulin Degludec this past year. But a lot of uncertainty about that. We have not seen the data yet. And in fact, many of the people at the company have not yet seen the data. It's been embargoed to date. So in summary, the controversies and uncertainties, I think, primarily are around the lack of peer-reviewed data on the adverse cardiovascular events. The major benefit of insulin Degludec is lower rates of nocturnal hypoglycemia. But the clinical impact of these events is controversial. In the ADA work group document, there is uncertainty about whether these really have clinical impacts on patients. There are arguments on both sides. As noted earlier, the non-inferiority goal was met, but the change in hemoglobin A1C was consistently greater with glargine than U100, except in one of the trials in patients with type 1 diabetes. There was also variation in the timing of insulin glargine in these trials, which some public comments suggested may have affected the rates of nocturnal hypoglycemia in those arms. So in summary, we concluded that there was moderate certainty of a small comparative net health benefit in comparison to insulin glargine or Detmer in patients with type 2 diabetes on basal-only or basal-bolus insulin. This is based on non-inferiority, so no significant differences in glycemic control, and a consistent finding of reductions of nocturnal hypoglycemia. There's greater uncertainty in patients with type 1 diabetes, as there's no consistent and statistically significant reduction in the hypoglycemia, the different hypoglycemic events. And for all types of diabetes, there are residual concerns about potentially higher rates of major adverse cardiovascular events in all subpopulations. So using the ICER rating matrix, we concluded that the insulin Degludec is promising but inconclusive. We received a number of public comments, in particular highlighting the fact that the hemoglobin A1C reduction was nominally greater with the comparator insulin than with insulin Degludec in 6 of the 8 trials and 6 of 7 trials comparing to insulin glargine. They also wanted to highlight that the definition of confirmed hypoglycemia was lower than that traditionally used. Again, the ADA recommends less than 70 as the standard. The trial used a more a tighter definition, less than 56, which our clinical expert has pointed out is often the level where patients start to have symptomatic events. We are also the timing issue about glargine versus Degludec was also highlighted in the comments, and the public comments also wanted to highlight that the target morning glucose levels were unusually tight. So again, a target insulin fasting glucose of 70 to 90 in the morning is very, very tight control, and tighter than has traditionally been used in even the studies of tight control or the recommendations of guidelines both nationally and internationally. And finally, the commenters wanted to make sure we highlighted the differences between the different formulations of insulin glargine, the U100 Lantus, which was a comparator in all of the trials, and insulin glargine U300, which is new and is known as Toujeo. And with that, do you want to take questions now?
No, we'll take them later, Jeff,
Okay.
after the economic analysis.
Great. Then I'll turn it over to Dr. Rick Chapman now for the economic analysis.
Thanks, Jeff. I'll be presenting the economic analysis, starting with our analysis of the incremental cost per outcomes achieved. Have no conflicts of interest to report, and I'd like to acknowledge Dan Ohlendorf, who was a great help with the modeling. The question we were trying to answer is, what's the cost effectiveness of insulin Degludec versus insulin glargine U100 in 3 populations: patients with type 1 diabetes, patients with type 2 diabetes who are on a basal-only regimen, and patients with type 2 diabetes on a basal bolus regimen. Say a little bit about these populations. The patients with type 1 diabetes were younger than those with type 2. The duration of disease was longer for the patients with type 1 diabetes. And then the patients with type 2 diabetes tended to be older and have higher weight. Patients with on the basal bolus regimens were higher weight than the patients on basal only, but had about the same duration of disease. To model this, our methods, we use the UKPDS outcomes model version 2. Unfortunately, that model does not include hypoglycemia in it, so we added a hypoglycemia submodel, and I'll talk a little bit more about that in a second. Our population were adults 18 and older with type 1 or type 2 diabetes, considered as separate populations. And it's important to note that the UKPDS evaluated patients with type 2 diabetes only, so the risk trajectories in the model are based on type 2 diabetes patients. We did model a type 1 diabetes cohort by setting age and other patient characteristics consistent with those reported for type 1 patients in the insulin Degludec trials. We used a payer perspective, which means we're looking at direct healthcare cost only, and we used a lifetime horizon for the model. This is the model structure. This is a pretty busy slide, so I won't go through all the details. Basically, a cohort of patients enter at time 0. We have demographic factors, risk factors, and event history entered for those patients. That came from the trials where we could get it. Where it couldn't, we got average values from the literature or used the defaults in the outcomes model. Patients go in each year. There's a chance of them having various events. If they have an event, that's recorded along with the associated cost and quality of life factors that would go with that. And then each year they also have a chance of dying. If the patients don't die, they go back into the model and cycle through another year until we've exhausted the cohort. We also built a separate hypoglycemia submodule to look at those effects. Here again, patients come in at year 0. Each year there's a risk of a certain number of severe hypoglycemic events, mild, moderate daytime events, and mild, moderate nocturnal events. Each of those events has an associated disutility for it. The lowest disutility was for daytime hypoglycemia, and that was around 0.03 disutility, so a decrement in the quality of life for the patient of about 1 day of life lost. For nocturnal, it was slightly higher, about 2 days equivalent. And for severe, the disutility was negative 0.012, or approximately 4 days of life lost. We also had a cost associated with severe hypoglycemic events, but not for mild or moderate events. All of those costs each year are summed up and added into the model. And again, we sum up each year until the cohort was exhausted. But some of the key assumptions in the model, because we were using non-inferiority trials, we didn't make any comparisons of glycemic control, and there was no extrapolation to downstream micro and macrovascular complications from differences in glycemic control. Our primary effect was the avoided mild, moderate hypoglycemic events in type 2 diabetes, which seemed to be the significant difference from the trials. As I mentioned, there was a short-term reduction in health-related quality of life for each event, which was different for the different types of events. And we assumed a cost for each severe event, but no cost was assumed for mild, moderate events, although we did vary that in a sensitivity analysis. We should note that there were no significant differences in hypoglycemia for type 1 diabetes patients, and you'll see that in our results. So here are base case results. The second and third column there, you see the results for the type 2 basal-only population. There was a slight increase in QALYs gained with insulin Degludec, an incremental increase of about 0.034. And this is from avoided hypoglycemic events, mostly nocturnal. There was also a slightly higher cost because of the higher cost of insulin Degludec. Ended up being a difference of about $12,000. And when you divide that $12,000 by the QALYs gained, you end up with a cost per QALY ratio of around $350,000 per year. For type 2 basal bolus in the last two columns, you can see there was a larger increment in QALYs gained with Degludec compared to glargine, about 0.237 QALYs gained. There's also a higher cost difference. These patients are taking more insulin, so they require higher doses, and that shows up in the cost difference of about $39,000. And we ended up with a cost per QALY ratio of around $166,000 for these patients, which is fairly close to the $150,000 cost per QALY threshold that many decision makers use. We should note that we could not calculate cost per QALY for type 1 diabetes in our base case because there were no differences in assumed differences in hypoglycemia between Degludec and insulin glargine, so there was no difference in QALYs gained. We did sensitivity analyses on our results. This is showing the results for the type 2 basal-only population. You can see the vertical line represents our base case of $353,000 per QALY. If you look at the first row there, we varied the relative risk of hypoglycemia for Degludec by plus or minus 20%. And you can see that it had a big effect on the cost per QALY ratio. It went from $175,000 at the low end to over $2.6 million at the high end. We also looked at the hypoglycemia disutilities and varied those, and you can see that also had a big effect on the results. There we got a variation from $46,000 per QALY, so something that looked cost effective, up to $1.4 million per QALY, depending on the disutilities that were used. Cost of insulin Degludec also had a moderate effect on our results, and you can see it goes from equivalent to glargine up to $837,000 per QALY. And finally, we also varied the cost for mild and moderate hypoglycemic events. We thought that there could be some cost associated with some of those events, so we varied that from the base case of 0 up to a cost of $100 per event. But even at $100 per event, you can see it had very little effect on the cost per QALY ratios. These are the results for type 2 basal bolus population when we did sensitivity analyses on the same variables. And you can see it's pretty much the same result. The model is very sensitive to changes in hypoglycemia relative risk or the disutilities that were associated with hypoglycemia. We also did a threshold analysis looking at the annual cost of insulin Degludec, and you can see the base case at the bottom there, which is the list price annual cost, about $2,873 for type 1 patients, higher for type 2 basal only, and even higher for the basal bolus as the dosing increases. And that gave us a total weighted average across those three populations of $7,800 of annual cost. We then varied that cost to see what cost would get us to ratios of $50,000, $100,000, and $150,000 per QALY. And you can see in the last column the total weighted average. It's important to note here that since we were not able to produce a cost per QALY for the type 1 population, we instead used the insulin glargine U100 cost as a reference price there and set the cost of insulin Degludec equivalent to that and included that in our weighted averages. So the weighted average to get to $150,000 per QALY, the cost would need to come down to $7,154. To $100,000 per QALY, about $7,000. And to get to $50,000 per quality, the price would need to come down to about $6,850. So not a very big difference to get to those ratios. We also did a scenario analysis. In our base case, if there were no significant differences in the non-inferiority trials, we assumed an average value for different variables. Here, we used point estimates regardless of the statistical significance. And we used point estimates for hypoglycemia events, HbA1c, and weight change. When you did this, you could see the results here. Type 1 diabetes continued to be dominated in that it was producing fewer qualities compared to insulin glargine at a higher price. Type 2 basal only, the cost effectiveness ratio increased to over $800,000 per quality with using the point estimates. And for the basal bolus population, also increased, but at a smaller amount, only up to $182,000. Some of the key model limitations in our analysis. Given the non-inferiority nature of the trials, our results were very sensitive to the relative rates of hypoglycemia events, as well as the disutility associated with these events, as we saw in the sensitivity analyses. We had limited long-term data on the effects of insulin Degludec, so we assumed that the effects observed in the short-term efficacy trials will continue over a lifetime and that they would remain constant over time. And we point out a need for research examining micro and macrovascular complications over the long term and over a longer term impact what the effects of severe and non-severe hypoglycemia events would be. Those were not included in our model because of the controversy surrounding those. Some of the public comments we received on the model, first, that our primary analysis does not consider numeric differences in clinical results. That's true. We did only use significant differences in our base case, but we did do a scenario analysis where we looked at those point estimate differences. Another comment was that US-specific cost and disutility measures should be used instead of international pooled estimates. We chose to use the pooled estimates for disutility measures because of the greater number of patients that were studied. And when we looked at US-specific cost, they were quite variable, the estimates that we found in the literature, but did bracket the cost that we were using from a Canadian study that had been converted to American dollars. So we stuck with that estimate. Our analysis does use wholesale acquisition costs, which does not factor in negotiated discounts due to the lack of publicly available information on what those would be. We received a comment that the outcomes model is not appropriate for patients with type 1 diabetes. We chose to go ahead with this model because it's a publicly available and transparent model, and as it turned out, there were no significant differences in our base case for the type 1 population, so this became kind of a non-issue. Another comment we received was that our model considers cost for severe hypoglycemia only. However, we did include cost for mild and moderate events in our sensitivity analyses. And finally, we got a comment about hypoglycemia cost and utilities appeared to be front-loaded and did not seem to be discounted appropriately. These were actually added in over time, and we did discount at a 3% rate for both cost and effects, as we did for the overall outcomes model. So our conclusions are that the use of insulin Degludec appears to confer small net health benefits in comparison to insulin glargine in patients with type 1 or type 2 diabetes, limited to episodes of nocturnal hypoglycemia. Our estimated cost effectiveness of insulin Degludec exceeded commonly cited thresholds. However, to achieve levels of value more closely aligned with patient benefit would require only relatively modest discounts in the range of 8 to 10% from the current list price. We also looked at the potential budgetary impact of insulin Degludec. So to do that, we first needed to calculate the population potentially eligible for treatment. You can see our estimates here. The majority of patients were patients with type 2 diabetes on basal-only regimens, about 3.5 million. a little over 1.5 million with basal bolus regimens, and a little over 500,000 with type 1 diabetes who were on basal bolus regimens. So our total population here was about 5.6 million. Now, we knew that not every patient would be taking insulin glargine, so we had to assume an uptake pattern. We assumed that 10% of patients would be taking Degludec by year 5. And it's important to note that this is an unmanaged uptake assumption. So this is assuming that there's no attempt to manage the uptake by different populations. We chose 10%, a relatively low uptake rate, because of the number of competitors already on the market and the recent introduction of insulin glargine U300 or Toujeo. So when we apply the 10% estimate to our year 5 treated population, we come up with about 560,000 patients total. We also wanted to look at the threshold, compare this to a threshold, but potential budget impact threshold. So we did that by calculating the target for overall healthcare cost growth of GDP plus 1%. We also looked at the number of new drugs that were being approved annually and the contribution of drug spending to overall healthcare spending. When you combine those in our calculations, we ended up with a 2015 through 2016 threshold of about $904 million for each new drug. And we'd like to point out that this is considered a policy trigger for discussion of managing cost of new interventions, not as any sort of budget cap or bright line threshold. It's just a signal that we may need to look at some management techniques. Our results at 5 years, you can see our eligible population here. The total was 5.6 million, 10% treated at 5 years, a little over 560,000 patients. The weighted budget impact per patient varies by the population because of the different doses that they're taking and the different population sizes. But you see the weighted total there is about $3,700 per patient. And the average budget impact per year summed across the 3 populations is $418.3 million, so well below our $904 million budget impact threshold. Some of the public comments we received, one, that our budget impact analyses use arbitrary thresholds and do not consider value to patients. I'd like to just point out that our first analysis, looking at cost per quality, does consider the impact on patients. And this is really intended more as a decision tool for whether or not management might be needed. The other comment we received was that an economic analysis of an intervention that's deemed inconclusive is inappropriate. However, we believe that decision makers still have to make decisions about whether or not to reimburse for different products, even in the absence of conclusive data. So we try to do the best analysis we can with the data that's available at the time. I think that's it.
Thank you, Dr. Chapman. The next portion of the program is a Q&A and a discussion of the presentations by Drs. Tice and Chapman. To begin with, I'd like to invite our clinical experts to come up to the table. Dr. Manuel Quinones and Elizabeth Murphy, please come up. And I would open the discussion for any panel members that have questions. Yes, Dr. Redberg.
Thanks for the very helpful discussions. I have a few questions, and I'd like to understand better how nocturnal hypoglycemia was determined and the clinical impact, because it seems like most of the differences in the regimens. And we have, of course, open label studies. So I'm not clear why they were open label and not blinded. I'll start with that.
The trials were not blinded because they come in pens that have a proprietary look to them, and so they were designed. They could not blind. That was the argument made with the FDA. We can get more from the manufacturers who were present as well.
Okay. And because looking at the data, it's clear there isn't much difference in the HbA1c. If anything, it's worse. 5 of the 7 trials.
Yeah, when you
The
look at the
glargine.
7 that had comparisons with glargine, 6 of them were nominally had greater reductions in A1C with the glargine rather than Degludec, but it was within the pre-specified equivalence threshold, or non-inferiority threshold, excuse me.
And then major adverse cardiovascular events, we're still waiting for that data.
We're waiting for those data,
So
yeah.
that's why I come back to that nocturnal hypoglycemia, because that seems to be the main difference. But I'm like, did everyone get woken up and have their blood sugar checked? How significant is this? I mean, it's not clear to me that this translates into a clinically meaningful something to the patient.
Understood. I think maybe we'll hear from our experts a little bit about that, but I would say the ADA acknowledges controversy around the significance of those events. There is certainly anticipatory anxiety about hypoglycemic events at night that some people cite as leading to decrease in quality of life. To detect these, patients had to wake up and check their blood sugar. So these are all self-reported blood sugars that were documented in journals that were kept by the patients. So by definition, I think the nocturnal hypoglycemic events required waking up, unless I'm not 100% sure whether any of the patients were actually wearing continuous glucose monitors, but I think not. I think the events were all self-reported from waking up and checking sugars.
So they may or may not wake up, and they may or may not check their blood sugar. I mean, they might wake up to go to the bathroom and then decide to check blood sugar.
I mean, typically, if someone has a nocturnal hypoglycemic event, it's because they woke up because of it. So it is typically, the nocturnal events typically are almost more severe because it's bad enough that it wakes you up. I think people don't typically, if they wake up and go to the bathroom, check their sugar. Unless
I
they're
don't know
feeling
what
low.
they did,
Yeah,
but it doesn't
no.
seem like there was a standard protocol for it.
Right, but I think it's, and you can comment on this as well, nocturnal hypoglycemia is a real and scary event. I mean, I think that is and it almost always in these studies, it is patients are woken up, and clinically, that's when they tell you about nocturnal hypoglycemia. More often than not, they don't bother to check their sugar. So there could even be more hypoglycemic events in real world that we don't know about because they don't check their sugar because they're just too tired and they know they're low and they eat something and then they go back to sleep. So.
Excuse me, before we go any further, I neglected to ask our clinical experts to declare their conflicts of interest. Dr. Murphy, do you have?
I have no conflict.
And Dr. Canonis?
Yes, I sit on advisory panels and speakers bureau for AstraZeneca, Novo Nordisk, GSK, and Johnson & Johnson, Janssen Pharmaceuticals.
Thank you. Go ahead. I'm sorry to interrupt you. You were about to say something.
Yes. One of the main concerns, and I think there's a lot of emphasis on nocturnal hypoglycemia, is that if you develop hypoglycemia during the waking state, you're alert, you are more apt to get help more quickly. When you're sleeping, that's when it becomes dangerous because if the sugar gets low enough, you might not actually wake up. So it's something that really concerns us as clinical providers, and I think this is one of the reasons for such a large emphasis on this.
Dr.
Certainly I
Brindis?
would be concerned, but I wish we had the data on the more serious events.
I'm pretty skeptical in general, but I probably believe the reporting on the hypoglycemia just because people do wake up and you would probably catch more if you had more. So the one thing I'll say about the nocturnal hypoglycemia, as Jeff mentioned, the target fasting glucose was very, very low, so the 70 to 90, so low that most physicians wouldn't consider that a safe target. I'm not sure why exactly they chose that, but when I look at the hypoglycemic data, I wonder what, in a real-world setting where you had a more reasonable and safer fasting glucose target, how much of a difference you would see between those two drugs, because I don't know of any clinician that uses 70 to 90 as a fasting morning target.
Dr. Brindis?
So, Jeff, you used the term anticipatory anxiety. So I share that, actually, related to the adverse outcomes reported to cardiovascular disease here. And we sort of are in an information dearth waiting for the results of the 7,000 study that the FDA evidently acted on an interim basis. So my question is really three parts. One, is there any, in the results that we have, the 67% increase, was there any difference in MACE related to the different types of diabetes? And then the next question would be to Rick, in your economic analysis with hypoglycemia, did you or did you not include any thoughts related to MACE? And then I'm interested in the experts' opinions as to whether they feel this is just a spurious finding of what, from their perspective, or is this a real concern that we should be waiting for in terms of our advice for our patients and clinicians for the results of the study.
So in terms of the stratified analyses, I mean, clearly they weren't statistically significant because it was borderline significant to begin with. I do not recall seeing it presented that way, and I didn't go back and parcel them out. There may be representatives from the company who can comment on that, but I did not see that presented in any of the FDA documents.
And then in terms of the economic analysis, we did not look at major cardiovascular events afterwards because of the lack of data.
The third part was the clinical experts. Was this spurious or?
You know, I think we've been here before with other diabetic agents. What set everything in motion was rosiglitazone by a meta-analysis by a cardiologist out of Cleveland Clinic. And this meta-analysis showed that rosiglitazone, known by its brand name as Avandia, increased cardiovascular outcomes. And then it just took off from there. And there were meta-analysis after meta-analysis. I have a slide when I give academic talks to show all the meta-analysis, how they're just killing people. Eventually what happened is, and we have to understand that meta-analysis is not true science. It's just something to give us an idea that we might actually design studies that are properly designed to answer the question. And when the record trial was eventually completed and the analysis showed that there really wasn't, except for some possible CHF hospitalizations, and was independently reevaluated and by Duke University, and verified that rosiglitazone doesn't cause an increase in cardiovascular outcomes, rosiglitazone was basically vindicated and the restrictions were taken off. Very recently, about 3 years ago, there was a drug called canagliflozin, goes by the brand name of Invokana. And Invokana faced a very similar type of scenario. When they looked at MACE, it almost didn't get approval because the curves really split very quickly. The FDA, in retrospect, we know this now, approved the drug because they thought it was just an aberrancy because in the first 3 months of analysis, there were no events in the comparators versus the canagliflozin. And so it was approved, and as the cardiovascular outcomes trials continued, that separation that you saw came right back together. And if you see the Kaplan-Meier curves, there's no blips there. It's just they're together. But if you magnify those first 3 months, there's a big separation. So I think the data for Degludec has not been made public, but the FDA obviously has seen it. That's why they approved it. So I would venture to say that when it does get unblinded and published, that we're probably going to see the same type of scenario, my personal opinion.
Christine.
Well, do we want to hear from Lisa?
Oh, so I'm sorry. Go ahead.
Yeah, I mean, I think what you point to is a unique situation with diabetes drugs, in that they can get approval without the outcome trials for cardiovascular outcomes. And you do not get approval on a surrogate marker for cholesterol-lowering agents, for example, where a lower LDL or a higher, as evidenced with the CTAF inhibitors, a higher HDL gives you approval. You need the outcome trials, and for the CTAF inhibitors, at least the ones we've seen so far for cholesterol, there was increased mortality. So diabetes drugs have traditionally had a bit of a pass with using A1C as a surrogate marker. And so we don't know until these outcome trials happen which way they're going to go. And so given that the requirements for diabetes drugs are less, and we know less about the cardiovascular outcomes, I think we really have to be cautious about which direction they're going to go, because we don't know until we have the data, as was just described. What the preliminary data shows may not be what the ultimate outcome is, and you don't know which direction that's going to go in. With respect to this drug, I guess we have to rely on the FDA. I mean, we don't have the data. They were concerned before, they're not now. That makes me think it's spurious in this particular case, but I think it points to a bigger issue with the FDA and whether they should wait for approval until they have the final cardiovascular outcome results.
Dr. Ohlendorf.
Yeah, I just want to. Hello? Hello? You can hear me? Okay. I just want to add some color to the question that Ralph asked around the model. So it's true that the model assumed only effects on patient utilities in terms of hypoglycemia. So we assume no effect of severe hypoglycemia on cardiovascular events. But keep in mind that there were no differences in the rate of severe events between Degludec and Glargine in any of the three subpopulations. That's all.
Now, Christine.
Okay, thank you. So my question is along the same lines. With these MACE events, how many of them might actually have been caused by a hypoglycemic event? In other words, were there sudden deaths? Were there MIs that perhaps were triggered that could be confusing the issue? That's the first part. And the second part is just to remind my colleagues on the panel that the only actual data we have is what's presented here in this slide, and otherwise we're relying on what the FDA has done. So if we're relying on the evidence presented, that's the only data we have.
I don't have the numbers in front of me, so I can't tell you for sure what proportion, but yes, there were examples of sudden death and myocardial infarction, so certainly hypoglycemia could contribute to the major adverse cardiovascular events, but of course all of these patients are patients with diabetes, which is a strong risk factor in and of itself for cardiovascular events.
Alex.
I know several of us in the panel are trying to wrap our brains around this importance or the implications of a non-inferiority design. On our voting questions, we are asked to vote on the superiority of Degludec versus Glargine based on secondary endpoint, nocturnal hypoglycemia, from a non-inferiority trial or set of non-inferiority trials. So I guess interested in your thoughts on what are the implications of the non-inferiority trial design as we think about comparing these medications?
That's a difficult question. There was a great discussion, I think, between the FDA and the companies around setting the thresholds for what would be a meaningful difference in A1C changes between the two groups, and the trials met those criteria consistently. So from that perspective, you can conclude that there is no significant difference in glycemic control between these two agents. There were small differences, but within the threshold. The secondary outcomes, I mean, most of us think of those as hypothesis generating in some sense, because the statistical machinery, the p-values, really are focused on the primary outcome of a trial, and anything else, unless you do some sort of correction for multiple comparisons, is really secondary. You shouldn't consider that the primary result of the trial. So you can't put as much weight on those findings, I think, as you can with the primary trials, the primary results.
And is that similar to if it had been a study designed to test superiority?
So, if it had been designed to test superiority in terms of glycemic control, you would have had to have seen a greater reduction in A1C. The way they designed the trial, they adjusted the dose of both Degludec and the comparator long-acting insulin to ensure that the glycemic control in the morning were essentially identical, and so it's not surprising that they found similar changes in A1C.
A couple comments. I don't think that the FDA was solely looking at drops in A1C and hypoglycemia. I think that they were looking at an overall picture. If you look at the changes in A1C, if you make this design the scale in a particular way, you can make the difference look this big. But if you look at actual numbers, the difference might only be this much. And I think that we really need to emphasize that. Another thing is that even though it wasn't significant, Degludec did have numerically superior numbers in fasting plasma glucose, as though they were titrated to reach similar values. In spite of this, they had there was a trend for lower hypoglycemia, which I think probably had some sort of influence with the FDA. But besides that, if you just look at the history of insulin, when we started way back in the 1920s and we were injecting extracts and eventually isolated insulin, one of the first things that were noticed was that when you injected insulin, it just didn't work the way that insulin works on a natural basis in the body, and that's where the race began to try to develop a basal insulin that could simulate more closely what's going on with the body. We came up with the first, it's referred to as an intermediate insulin now, but it was the basal insulin that we have, which is NPH, that had an extended period of action, but it had peaks that were not good for us. And then we made a major milestone when the new analogs that came into being that in many areas made NPH go away.
Manuel, we're going to get more into the context and history during the roundtable, but we need to keep to our agenda a little bit at the moment. Thank you. We still have a couple of questions.
Okay. We have one more question. Dr. Redberg.
Rick, I think it's cost effectiveness, because it seemed to me, there were some assumptions that I need to understand, mainly, again, to the nocturnal hypoglycemia. I think you said that you gave it 2 days of life lost. And looking at the data that Jeff presented in the quality of life studies that were done, there was no difference in quality of life in those trials. So now you are assuming a big difference in, seems to me, quality of life, and I'm wondering on what basis, because it seems to me the whole cost effectiveness was driven by that.
Yeah, we did not use the quality of life results from the trials. I don't believe we had anything that was broken out by type of events. So we didn't have any data from the trials on nocturnal versus daytime hypoglycemic events per se, as far as I recall. We did find quite a range of utility values, dish utility values in the literature for hypoglycemic events. Some that went up to as high as 17 days of life lost, which would be about equivalent, when you look at other studies, to having a myocardial infarction. So one of the things we did, and this is more details in the report, is we did adjust those values downward that we found in the literature to just account for the time that people were spending in those events. And so for mild, moderate events, I think we were assuming 15 minutes per event. But even with that adjustment, we came out with those dish utility values. We couldn't find anything that was in the literature that was more in line with where we thought it would be. One of the things that we did receive in our public comments was also the thought that there may be some adjustment by patients to hypoglycemic events, and that after they've had 1 or 2 events that they may become more accustomed to them and that this utility value would be lower. However, we didn't have data at the time to model that. So.
I'm going to have to cut it here. We're running behind. So the next portion of our program is public comments. And there are two who have requested to make a public comment. I would ask them to limit their remarks to no more than 5 minutes. We're being generous. There are only two speakers. The first of whom is Kevin Ambrose. And would you please state your conflicts of interest, if any?
Sure thing. Thank you very much. My name is Kevin Ambrose. I'm a medical liaison with Novo Nordisk, and an employee, of course.
Thank you.
So thanks for the opportunity to discuss here today in the public comment period. There's just a few items that I want to mention that's very relevant to today's discussion. First off is the effects of hypoglycemia, and specifically top-line results from the switch studies, okay? So this is in response to the revised draft report where ICER states that the differential timing of the administration of the basal insulin dose may partially explain the differences in nocturnal hypoglycemia rates. To address this potential confounding, Novo Nordisk conducted 2 randomized double-blind trials, one in type 1 diabetes, the other in type 2 diabetes, comparing insulin Degludec to insulin glargine U100.
Sir, excuse me, where were those published?
This is pre-publication, just came out with the last couple weeks. But for the benefit of ICER, just wanted to make sure that they were aware.
I just want to state that we really respond to published evidence, but as long as you've qualified that, please continue.
Absolutely. And the only reason I'm bringing them up, it's very germane to today's discussion. In these studies, switch 1 and switch 2, patients are randomized equally to either AM or PM dosing. Okay? Again, very important, randomization, AM or PM dosing. Recruitment for these trials is completed, and a recent press release described the findings from Switch 2, in which 721 people with type 2 diabetes were randomized to crossover treatment with Tresiba and insulin glargine U100 in combination with metformin. The overall purpose of the trial was to compare the hypoglycemia occurrence in people with type 2 diabetes treated with Tresiba or insulin glargine U100. As reported in the press release, top-line results confirm comparable A1C reductions with Tresiba and insulin glargine U100, and with Tresiba, significant reductions in treatment-emergent severe or blood glucose-confirmed symptomatic hypoglycemia, and also with Tresiba, significant reductions in treatment-emergent severe or symptomatic nocturnal confirmed hypoglycemia during the maintenance period. Again, these results are pending publication. Switch 1 results are being analyzed now. At the very least, this helps to reinforce ICER's initial conclusion regarding nocturnal hypoglycemia and benefits with Tresiba, okay? The second item I want to discuss is the MACE, or major adverse cardiovascular events, with Tresiba. Novo Nordisk would like to reiterate that the pivotal studies conducted to obtain FDA approval for Tresiba were not designed to assess cardiovascular risk and should not be interpreted in this context, okay? Therefore, at the request of the FDA, Novo Nordisk began recruitment for the Degludec cardiovascular outcomes trial in October 2013. This trial is also known as DEVOTE. DEVOTE is a randomized, double-blind clinical trial comparing the cardiovascular safety of Tresiba to insulin glargine U100 in patients with type 2 diabetes and at high risk for cardiovascular events. The trial, of course, is still ongoing. However, the FDA did approve Tresiba based off the interim analysis that was submitted. At the time of the approval, Dr. Curtis Roserbrow, Director of the Office of Drug Evaluation, stated, "We informed the sponsor that we would require the information from a dedicated cardiovascular outcomes trial that had a reassuring point estimate and excluded a risk margin of 1.8 in order to allow marketing. The interim data from DEVOTE fulfilled these criteria." Dr. Roserbrow goes on to state that the interim results from DEVOTE are reassuring and the team is recommending approval. I agree with the recommendation. Again, the pivotal studies were not powered to assess cardiovascular risk, ergo the DEVOTE trial. Okay, so very important. So Novo Nordisk, of course, agrees with ICER that the DEVOTE trial will more conclusively answer remaining questions about any potential difference in MACE with Degludec compared to insulin glargine U100. Okay? Final point, of course, treat to target study design, as we wrap up here. In the revised draft report, ICER states that in 6 of 8 trials, the reduction in A1C was nominally less in the Degludec group than in the comparator group. I want to reiterate that the FDA recommends a treat-to-target trial design for all new insulin products, okay? In treat-to-target studies, the insulin dose is adjusted for each individual subject using the same titration algorithm based on pre-specified glycemic targets. Those include fasting plasma glucose, A1C, and/or postprandial plasma glucose. Since treat-to-target trial design is intended to obtain the same level of glycemic control, it is not expected to achieve superiority in glycemic parameters. While there may be numerical differences in A1C results between these groups, neither clinical nor statistical inferences should be drawn from the differences.
Thank you very much. Appreciate it. Our next speaker is Rochelle Beria. Would you please state your conflicts of interest?
Good morning, Mr. Chairman, panel members and colleagues. I declare my conflict. I'm Dr. Raquel Beria. I serve as Vice President and Head of the Diabetes Medical Unit at Sanofi. And on behalf of Sanofi, I would like to thank ICER for the opportunity to comment at this meeting. Sanofi is committed to helping people living with diabetes and has a long, proud history of bringing innovation through new therapies and patient programs to help to improve patient outcomes. We share ICER's commitment to transparency when assessing the value of treatments, which preserves fairness and allows third parties to validate conclusion. With this in mind, Sanofi commends ICER for basing their analysis on peer-reviewed published results and revising the draft report based on feedback from numerous stakeholders. As an example of ICER's rigorous literature review and error in a publication from Ratner and colleagues in the estimate for severe hypoglycemic episodes in patients with type 2 diabetes treated with basal insulin was recognized and subsequently excluded from the analysis. We just heard a reiteration of a recent press release from Novo Nordisk. We encourage the submission of full results of the SWITCH study as the peer review process will allow this trial to be vetted by independent experts and to finally determine its merits. Our review identified at the very beginning a number of shortcomings related to the ICER's initial analysis, and interested parties can in fact find Sanofi's comments on the ICER website. ICER addressed, indeed, several of these recommendations by acknowledging limitations or uncertainties surrounding comparative clinical effectiveness in economic modeling. While we appreciate ICER incorporating this feedback, we also believe that recommendation to the economic models should also have been implemented. Finally, ICER's framework for assessing health system value may hold the potential to discourage innovators from developing treatment for diseases with high prevalence. ICER applies a little bit of an one-size-fits-all approach regardless of the value generated by individual products, as treatment for more prevalent diseases such as diabetes will by definition have a higher budget impact. Despite these very specific critiques, Sanofi would again like to thank ICER for the opportunity to comment on the report, both in writing and in this public forum. If panelists or any other stakeholders require further clarification, we will be happy to address any question during the voting and panel discussion session. I thank you very much.
Thank you, Dr. Beria. At this point, I would like to turn the meeting back to Dr. Weisberg.
I trust that some of the residual questions from our morning presentations we'll have a chance to address during the discussion around our voting questions, so keep those top of mind or make some notes for yourself. As has been pointed out already, we will be voting on the questions on the basis of the evidence as presented, and feel free to ask any questions, clarifying questions, probing questions of our reviewers, as well as our clinical experts, and I'll caution our clinical experts to respond only on the basis of the published evidence and the analysis that has been presented during this portion of the meeting. Matt, help us understand how we'll do this.
Sure. So all of the panel members will notice that there's a small red remote in front of them. So I'll give you some brief instructions on how to use the voting technology before we dive into the voting questions. So to turn your remotes on, you can hold the on-off button for a couple seconds and you'll notice the screen come to life. Let everybody do that for just a second. So once you've done that, you'll notice it asks you for a voter ID. So if you look at the back of your named tents, there's a little post-it note with a number on it. So you can just enter that using the keypad and then press join. So that'll be the top right button that asks you to join. We're waiting on one more person to join. All right, we're all set. So moving forward a little bit, for our practice question today, we have, what is the best Valentine's Day gift? So you'll notice that on the screens of your voting remotes, there are now 5 options with an arrow displayed below the lowest one. So you can use the up and down arrows on your keypad to navigate between those. And once you've highlighted the selection that you like, you can press the top right button again that says send to choose. We'll do a post-results analysis there. Yeah.
I'm taking chocolate.
We did a dry run of this yesterday with two ICER staff members, and they both chose F, so we'll be interested to see if that happens again today. So we're waiting on 3 more people to submit.
I was looking for this one.
It.
Thank you so much.
Yes, okay.
Okay, we know that voting is hard, but not voting has consequences, so please vote.
All right, so we're waiting on one more person to submit their vote. So if you can check your remotes, if you still see the letters A through E, then you just need to press send using the upper right button. Perfect. Sometimes it displays a little bit strangely, so we'll just have to restart that question, unfortunately.
While we're waiting, because of time constraints, I skipped over issues that are well known to our panel in terms of how we vote and the structure of the voting questions. But for those of you unfamiliar with the ICER process, I refer you to our methods in detail on the website.
All right, so you should be able to rejoin the voting presentation now, so if you can just, once again, power on your remotes and enter in your participant ID number. So we're waiting on 2 more people to join, and then several more people to submit their choice for the best Valentine's Day gift.
Yes.
We've got 2 more votes, 1 more vote. All right.
There we go.
So quite a wide distribution.
Well, in addition to stratifying by gender, we should note that Matt is a relative newlywed, having been married only 6 months, so that's a relevant consideration in this
I think
question
that
as well.
defaults me to the F category, the all of the above.
Okay. Since everybody now has mastered the voting booth, we're going to go on to the meat, the substance of our voting. So our first question is found on the next slide, and it's for type 1 diabetes. Remember, we looked at the 3 clinical subgroups. And I'll read it. For patients with type 1 diabetes, is the evidence adequate to demonstrate that the net health benefit of treatment with insulin Degludec is greater than that of treatment with insulin glargine U100? Yes or no? So in order to help you decide how to answer that vote, we open the floor up for any questions of our experts to review or clarify the data. Does this represent confusion or certainty?
Yeah.
In the absence of any questions, we would remind you to jot down any notes you might have as to why you're making the decision you're making, and then go ahead and press yes or no, enter on the voting machine.
And here's where we...
Yes.
We are just waiting on one more person to submit their vote. All right.
So is that our number of voting? Okay. So we have a fairly clear-cut opinion on the behalf of the panel as to no in diabetes type 1, in which case we can skip over the value questions for the individual and society healthcare budget and look at the questions for type 2 diabetes basal only. This question for patients with type 2 diabetes based on basal only insulin regimens, the one long-acting drug, is the evidence adequate to demonstrate that the net health benefit of treatment with insulin Degludec is greater than that of treatment with insulin glargine U100? Yes or no? And we have some questions already. Paul, please.
I know since this really hinges on the difference in nocturnal hypoglycemia, I was wondering if there were final comments from the experts on whether 1.8 days per episode is accurate, reasonable. The reason I just looked up what NICE assumed for colonoscopy. They said 0.9 days, which would mean if those were equal, that 2 colonoscopies equals 1 episode of nocturnal hypoglycemia. I mean, I think it gets to that the patients are, it's very inconsistent and it's very difficult to extract these accurate utilities from patients. So do you have any last thoughts on that, since it really hinges, I think, on...
Yeah, I think that the difficulty, as Rick discussed, is not all nocturnal hypoglycemic events are the same. And there's a wide range of impact on those. And I think that, going back to Rita's comment, one thing that we can look at is the quality of life outcomes in these trials as perhaps an indicator of how severe those hypoglycemic events were. And they weren't specifically geared towards that, but as some sort of an overall marker of whether or not the hypoglycemia was impacting quality of life. Those would suggest to me that it wasn't having a big impact. But it's very hard to come up with an exact day because it really depends what happens with the hypoglycemia. But the other thing I'll also jump back to is just that it's unclear to me what the rates would be in a real-world setting with a more realistic fasting glucose. And that's something really to consider. And also the fact, as was pointed out, they did lower fasting glucose, but yet A1C goes in the wrong direction. So in a real-world setting where you've got an even higher fasting glucose, would the A1C difference be even higher? Again, hard to know.
We have a couple of additional questions. Joy?
So I have 2 questions, actually, one about the clinical effectiveness review and one about the model. So with regards to the clinical effectiveness, Jeff, I wonder if you could comment on what biases you think might accrue from the fact that all of these trials were open label or non-blinded. And I have to say, I find the justification that it couldn't be blinded difficult to accept, since we're now being told that there are double-blinded trials which are not yet available. So anyway, that's my first question.
Yeah, I mean, in general, blinding has less of an effect on more objective outcomes like the glycemic control, though there are studies where even objective outcomes have slight differences in blinded versus unblinded trials. I think it's a bigger issue when you're talking about self-reported outcomes, which I guess even the hypoglycemic events were because they had to be recorded, but I think quality of life is much more likely to be impacted if the patients felt like, oh, if I'm randomized to this newer, longer-acting insulin, oh, I got it, oh, I'm going to have, fewer hypoglycemic events, and feel better about that, and they may report higher quality of life. And those who were randomized to continue their usual insulin or starting on the older version may have, again, I feel bad about not getting the new thing, and thus has a small but real impact on subjective outcomes like quality of life. I think that's where it would have the biggest effect and not on the actual glycemic control.
And the model?
Oh, yeah, so my question about the model is just, you mentioned in the report 3 models from different European countries that came up with much lower incremental cost-effectiveness ratios than the ones that you found in your model. And I just wonder what you think the difference in the, was it a model thing? Was it the cost of the insulin? What was different that made for those differences?
Yeah, I think the biggest difference is those were short-term models. They were looking over a year.
They weren't lifetime.
Their year time horizon, and ours was lifetime. So I think that really accounted for the.
They're projecting the costs out over lifetime differences in costs, or?
Well, actually, I think they just stopped at the 1 year.
Okay, yeah, so, but in your model, you were projecting
out
costs
over the lifetime, yes.
over the lifetime. Okay,
Thank
thanks
you.
very much.
Rena and then Jeff.
I'm definitely troubled by this target fasting glucose being so low when it's different than clinical practice and different than published guidelines for diabetes. Wondering whether you think this was even, intentionally designed to elicit more hypoglycemic events, especially since it's the morning fasting glucose being so low. And do we know whether he might have left the room, whether the study designed to look at the MACE events is going to use that same target?
I don't know about the MACE trial, and I have no other conclusion than the one you just drew.
The only other comment I would make is that I think that the design of these studies in question are probably no different than other studies that have been recently conducted where GLP-1 receptor agonists that don't cause hypoglycemia are being compared against basal insulins. And they're using the same criteria that's put out by the FDA and being really stringent on their fasting glucoses.
But why wouldn't they use the same targets that are in ADA guidelines?
You would have to ask the FDA.
I don't think that target was at FDA. I think that FDA said you have to treat to target, but I don't think they dictated what the target was.
Thank you, Jeff.
My colleague, Dr. Fox, has adequately expressed my paranoia.
Thank you. You can use a Donald Trump-like approach and say, people say that. Other questions?
I might make one comment, just one thing that I probably should have highlighted in the evidence review is that the absolute rate, the annual rate for hypoglycemia is much, much higher in patients with type 1 diabetes. So it was on the order of 40 to 50 events per 100 person years versus on the order of 1 to 2 in the patients with type 2 diabetes, so much lower because you don't need to be as aggressive with just an insulin as when you're giving a basal and a bolus insulin in patients who can't make their own insulin.
Any other questions? So let's return our attention to the question as stated, diabetes basal only for patients with type 2 basal only insulin regimens. Is the evidence adequate to demonstrate that the net health benefit of treatment with insulin Degludec is greater than that of treatment with insulin glargine U100? Please vote yes or no. Clickers. So we have 1 yes and 15 no. Let me just double check now. Because there was an expression of yes, we don't want to go on because of the majority. Okay. So given the majority felt that this insulin has not demonstrated that benefit, we will not go on to the care value questions in this subcategory of diabetes basal only. So we can turn our attention to the question on slide 49, diabetes basal bolus clinical effectiveness. And remember, Jeff pointed out some of the differences between all three groups. For patients with type 2 diabetes who are on basal bolus insulin regimens, is the evidence adequate to demonstrate that the net health benefit of treatment with Degludec is greater than that of glargine, yes or no? So in this subgroup, questions about the data, clarifications, additional thoughts? And Jeff, remind us the clinical differences for the patients in this subgroup compared to the basal-only group.
Well, in terms of hypoglycemic events, the annual rate was, 11 to 14 events per 100 person years, again, versus 1 to, I guess, up to 4 in the 4 studies of basal only in patients with type 2 diabetes.
And remember, in your packets, you have the data tables to help you remember those specific numbers if you wish. And of course, we're again asking you to write down the reasons and justifications for your votes, so make sure to do that even if you're voting already. Any other questions about this particular subgroup? Chris.
Just a quick question. So there was really just the one study on this subgroup. What is your assessment of the quality of that study overall?
The quality of all of the studies was actually very high, other than the fact that they were unblinded, that they were open label. That was the major issue with all of the trials.
Other questions? So having recorded, oh yes, please, Luanda.
One perhaps naive question, but if the surrogate endpoint is hypoglycemic episodes, why, just comments on why would it just be essentially symptomatic hypoglycemic episodes? Because these patients, as I understand it, suffer from dysautonomia, so there's a disconnect between symptoms and hypoglycemia. So if reducing hypoglycemia is the desired endpoint, why just sort of analysis based on symptomatic episodes?
Right, I will jump in initially and then let the experts comment. I think most, as I think I've already stated, most of the episodes at night are by definition symptomatic. These are patients who are waking up and checking their sugar. So I think most of these are symptomatic. Patients develop hypoglycemic unawareness, but then most clinicians then try and back off on the intensity of treatment and help them regain their sensitivity to hypoglycemia again before pushing a tight control again. I think, though, I'll let my experts comment on that.
Well, that's all true, but what I was going to comment, I think they expressly excluded patients with frequent hypoglycemia or hypoglycemia unawareness. So we haven't really talked about that, but that also, those are the patients that this is most important for, and they were expressly excluded in these trials. So presumably the patients in this trial, since they didn't have the hypoglycemic unawareness or frequent hypoglycemia, are going to feel the episodes. So I think that that is a reasonable outcome, but it throws into question the clinical relevance because the patients who would most benefit from the outcomes they found were excluded from the trial.
But they did report their hypoglycemic events by 2 categories, I believe. And one were symptomatic, but they also used a more rigid criteria of blood, because the patients were doing home glucose monitoring. They also looked at the percentage of patients that would reach the level of less than 56 milligrams per deciliter. And I think what they found there is that in type 1s, in the 90s was the report, and that lessened quite a bit in the type 2 diabetics because they tend to be more insulin resistant, so they're probably not going to develop as much hypoglycemia.
I find it frustrating that there's so little hard data as to the health impacts quantitatively for nocturnal hypoglycemia given the prevalence of diabetes. How come we don't know what the percent of strokes or other long-term sequela is from nocturnal hypoglycemia?
You know, it's a great question, and I also think about total hypoglycemia, and I know that it's been sort of a given within this setting that the hypoglycemia is accounting for some of the cardiovascular outcomes in some of those other trials, but I actually don't know how well documented that even is as to what caused in ACCORD, for example, the increased mortality. It's certainly been hypothesized as hypoglycemia, but the data hasn't necessarily panned out on that. So I think we haven't done a good job in the field of figuring that out. It's a very good point.
Since we're harping on the hypoglycemia issue and criticizing these studies essentially for their kind of vague descriptions of what it means, whether it's symptomatic or actual numbers, and whether we're capturing much of it or if some of it's asymptomatic, is there actually a gold standard that was violated, or is this just the state of the art or poor science in this area?
I don't necessarily know of a gold standard other than some of the things that were discussed. I don't know what you found.
Yeah, I mean, that out of the experts. I mean, certainly the standard recommended by the FDA is less than 70 for a definition of hypoglycemia. If they had used that, their event rates would have been higher. You may have actually seen more of a difference. I think less than 56 is, heard from our experts, that patients are much more likely to be symptomatic at that level, so that may be a more clinically relevant threshold, but it's not a standard that's been out there for research.
So my question wasn't really about the number, because where there's a number, you can argue about whether it's likely to lead to long-term outcomes or not. It's the fact that we're concerned that there may be times that it's not being identified, that patients may be not recording them. A number's a number, so that's my real criticism, and I think others here too.
Well, perhaps your question is getting at whether there are reliable, continuous monitors that people can be using, and my understanding is the answer is no at the moment. Maybe folks can say.
I mean, there are continuous glucose monitors. They're problematic, and they're expensive, and any low, usually in studies that use those, they require any trigger for a low glucose to be confirmed with a finger stick because of the concerns about the reliability. So,
any other questions or comments prior to the vote? So, turn your attention to the vote once more in the basal bolus category, yes or no, in terms of care value of treatment. I'm sorry, I was looking ahead. In terms of the net health benefit of treatment. Degludec better than glargine, yes or no? Has everybody voted and recorded their thoughts? In which case we can display our results. So now we're 14 and 2. Again, not requiring additional discussion of the care value, though the economic analysis is there for all to read. Any other concluding comments from the panel as to the reasons for your vote? We would like you to now pull back the curtain and tell us what went into your thinking.
For me, the concern is related to the major cardiac events, and we can't rely on data we don't see. The FDA did, but it seems to me that the FDA is a government agency accountable to the taxpayers, and the taxpayers should see the data, and we're taxpayers and we don't see the data. So there we are.
Strong statement. Wanda?
I had the same conflicts that I think a lot of the panelists did in terms of the strength of the surrogate. So the surrogate here is symptomatic hypoglycemia, and it seems as if that is based on essentially a hypothesis from the ACCORD trial that these episodes of symptomatic hypoglycemia translate into increased risk. But it's not clear to me that episodic hypoglycemia versus sort of basal level of glycemic control, that we actually have the data to say that that's the true marker that either we should be measuring or trying to interdict or change the level of. So I had major questions there, and since the data seems to be discordant with regard to MACE and the available data set, I had the same question as my colleague in terms of wanting to see the final MACE outcomes.
Rita, and then Marcia.
I certainly agree with what my colleagues have said, and I feel that it's very hard for us to make any kind of informed decisions on the basis of very incomplete and really frustrating data. Like I find an open label trial that doesn't have differences in objective outcomes and has subjective outcomes of, as best as you've tried to explain, it's clear that there wasn't a standard for the nocturnal hypoglycemia, which was the only difference. There weren't differences in HbA1c. And I find it very disappointing that the FDA accepts this evidence and then, makes a decision on the approval when it's still waiting for the clinical trials of the major adverse cardiovascular events, because we have lots of experience in the past where interim data do not reflect the final results. And it's not like there was a big rush to get that we have insulin's on the market now, and I think we should, the FDA should have standards that require actual clinical evidence of safety and effectiveness, and that now we're in a position of having to make, very frustrating and uninformed decisions because the evidence just isn't there. And so certainly I can't say that there is evidence of safety and effectiveness and that it's not even non-inferior.
Marge?
Is this on? Hello? Yes. Well, I'm kind of an outlier voter. I was persuaded by the improvement in incidence of hypoglycemia and thought that it was meaningful enough to suggest that this will have an impact. Not an impact to have a good care value, mind you, but it was strong enough to meet the bar of showing significant improvement.
Thank you for your courage. Joy?
So I was also a no voter, and I would agree with what previous comments have been made about that. The other thing that concerns me is the very strict glucose goals that were set in these open label trials, and whether in a setting of more like typical practice, you would see differences in hypoglycemic events similar to these, or whether or not. I mean, you just don't know. So again, frustration at lack of really applicable evidence to the real world setting, and perhaps finding differences that aren't really important in terms of what could happen to diabetics in general.
Thank you. Ralph, and then Bob.
And so I acknowledge all the wise comments, sage comments made by the panelists, but I will say that this is an area of intense interest in terms of type 2 diabetes with basal bolus therapy, because when you look at absolute differences related to hypoglycemic events, there is this signal that where there is a substantial number of hypoglycemic events in patients who are on bolus therapy with type 2 diabetes, that there is a signal. So we should keep an interest in this going forward, because it may be a subpopulation of potential value.
I'd just like to kind of chime in and point out that we're not FDA, and we don't have the same purview, same job as FDA does. FDA has their hands tied in a way that we don't. And quite frankly, the bottom line that I think a lot of people are actually getting to is these studies should have been better. They should have actually addressed us rather than the FDA, at least much more so than they obviously did. And going forward, that was the one clue that I'd actually hoped to get across to the companies that are actually producing these drugs. Non-inferiority trial approval, that's a real low bar with the FDA. It's the only bar that we can actually all agree on. That's why we're stuck with it. It's not a particularly good one, and griping about the FDA doesn't do, we're not going to move that ball very far. But marginal change, incremental kind of change, stuff that hypoglycemic events here that you apparently didn't even realize were going to come up, and you should have actually, the studies weren't designed right for the questions that we're having, that we're throwing out here. And that's an issue. Design the studies better from the outset. Shoot a little higher than FDA's non-inferiority from the get-go, and we'll all get there a year or two earlier.
Our votes send a message. Any other comments, questions about your thinking on these votes? Please.
Just a question that may be provocative. Let's say it was non-inferiority, but it cost a whole lot less, and we knew that. Would we go on and vote on value?
If the votes were still no in terms of the health benefit?
Right, we got the same votes looking at the evidence, but the cost was a lot less. The other part of the value equation. Would we go ahead and vote on value?
Sadly, we don't run into that terribly often. But
I want to see that new chart.
And we can be cynical about that, but in the in this world, this new world of the value proposition, I know when VCs look at devices and stuff, they're looking for stuff to cost less, and it might be a message we can send that if you come up with something that costs less that does it just as good, that might have high value. So
I think that's true, and we publish our full economic analysis in any event, of course, and that's there for people to look at. In terms of our CTAF committee process, I don't recall that we've come to a firm conclusion on that. Steve, do you want to make a comment?
It has varied a little bit as we've developed our approach, and we could have had you guys vote on value on this as well. I mean, it's actually something I was reflecting on, whether my initial judgment about whether we should or shouldn't have voted on value was consistent with what we've done in the past. So we need to firm that up, but in general, we try not to view all of our voting decisions about whether we're trying to send a specific message or not. So we might very well, and we often do hope that our votes are clear indicators that can help people who are making decisions. So your question's your question of me is well taken, and I think we will revisit how we can make very, very clear when and when we will not make value votes.
Right. I mean, I look to Steve because in previous votes, when it's been much closer, we actually have gone on to consider these other issues, but this was quite clear, near unanimity. Any other comments?
Yeah, I was a no voter in the same issues, the cardiovascular events and the squishiness of the definition of nocturnal hypoglycemia.
Final comment? In that case, we have our votes. We'll be writing up this section of the report, and we go on to our roundtable, which is where we get to unleash our imaginations and really be a little bit more provocative with our clinical experts and requirements of evidence in the future. And we would like to invite 2 additional roundtable policy members to approach and take a seat. That would be Neil Kahatsu and Tony Van Goor.
Neil.
Okay, here's where I get to walk right up and ask people some questions. So as was pointed out, we always do a tech assessment at some point in time. Why? Because people have to make decisions based on the evidence available to them at some point in time. Now, the question's been raised clinically whether clinicians really need to make a decision about this new insulin given the availability of alternatives. And we'll ask them that. But I want to start with our medical directors who do have to make a decision at this point in time because such mechanical things as formulary placement and tier placement and prior authorization and step therapy all have to be considered and is your duty to your health plan members and for your instructions to your participating clinicians. So, Neil, would you like to start?
Sure, I can give maybe a little bit of context because department is both a payer, meaning contracting with 22 health plans, but also a direct, in a way, funder of care through the fee-for-service side. So since the Affordable Care Act, and this applies obviously to our future discussions here at CTAF, with the Affordable Care Act, essentially all full-scope Medi-Cal members are in one of 22 health plans. So the large area outside of that would be those who are undocumented who are eligible for emergency services, so pregnancy and emergency department. So in that setting, since with a few exceptions, most of the medications are carved into the capitation rate. Plans are given the flexibility, and so I look forward to my colleagues speaking. The 22 health plans are given the flexibility, and they don't all have the same utilization review criteria. Some use PBMs, and mainly are internal, I think. So the fee-for-service is really a small subset. So they see a small percentage of the patients, those coming into health plans over a few months, someone may be eligible. In that area, these types of drugs would be on a standard utilization review protocol. You have to get a treatment authorization, and a clinical pharmacist designated for that would look at that. So the real value to Medi-Cals, to the 22 health plan medical directors who have contracted with DHCS, who will look at this evidence as they in turn make their criteria. So it's very useful. On the fee-for-service side, just for completeness, they have criteria on reviews that are actually in the law. So the safety of the drug, effectiveness, very similar to what we just discussed. Essential need, is it the only drug that can do it? Hepatitis C curative treatment. Potential for misuse and cost. So those are the fee-for-service criteria. And I think just our experience with 22 health plans, they look at things in a similar way, but they very much appreciate systematic reviews and very in-depth, this kind of in-depth review each health plan obviously can't do.
Thank you. And I know both health plans in their decision-making get lots of clinical input. Can you share a little bit about what clinical input, feedback from your networks, and medical policy decision-making you've gone through with this?
Right. Blue Shield of California actually at this point has not placed this medication on the formulary. One of the important aspects that we were looking at is that we don't have the results yet, and I think our colleague mentioned from SWITCH, the SWITCH 1 and 2 studies, and also from DEVOTE yet, and we really need that in terms of a formulary placement decision. That means what happens at this point, we do have authorizations for this medication, Tresiba. We essentially would require for non-formulary authorization trial of another medication, and the typical medication here would probably be Lantus or Glargine. The criteria that we've used to look at this medication so far has involved, first of all, again, FDA approval, very important to us, obviously. We note that there's a hypoglycemia indication that's being sought at this point in time. That has not yet been specified by the FDA, and that's something that we're looking towards. And again, certainly the SWITCH studies will help tell us that. We looked at certainly the efficacy of the medication. We looked at the results of the non-inferiority trials. We were very concerned, too, about the data concerning nocturnal hypoglycemia. We had difficulty interpreting it, and I think some of the salient points brought up here that were important to us is the definition of hypoglycemia to begin with, and more importantly, I think the health impact of the medication also was a consideration that we had undertaken. Certainly we looked at safety and MACE. That was extraordinarily important in our deliberations at this point. We really need more information about the incidence of cardiovascular events and the safety to our beneficiaries in terms of this medication. Other considerations, of course, cost effectiveness, unique advantages, and in terms of our deliberation, we essentially determined the major advantage that we could really hang a hat on at this point in time was the flexibility of the dosing, and that hasn't been brought up to this point, but that's something that we looked at that could conceivably result in a conceivable advantage. To what degree? Uncertain, but a conceivable advantage. The potential for off-label use, consensus guidelines, again, probably not a concern. We also tried to estimate the utilization of this agent, and actually, I don't have the figures for Lantus. I was not able to get those to compare against insulin Degludec. But we, to this point, have had very few requests for this particular medication, something to the order of about 130 or 140 over about a 4-month period, which is a very, very, very low demand for this medication at this point in time. Putting all that together, again, we came up with the conclusion that we're hopeful. We have not shut the door on this medication whatsoever. By no means have we shut the door, but we need better information concerning the impact on quality of life, the impact of the hypoglycemic events, the claims that have been made, and we also need much more conclusive information on the safety of this medication, particularly with regard to cardiovascular events.
Thanks, Tony. Now, many of us are or have been frontline clinicians. I wonder when we can get away from war-related descriptions of being in clinic. But we are on the lines with patients trying to make these decisions. And I think we've heard that hypoglycemia, particularly nocturnal, is an important issue for patients. And there might be multiple ways to address it. We've heard 2 described already, adjusting your targets or perhaps switching agents. And I'd like to hear from Manuel and Lisa as to how you approach a patient who starts telling you they're experiencing hypoglycemia and how you educate them about it in addition.
Well, there's, first of all, we need to differentiate between type 1 and type 2 diabetes. I mean, the epidemic itself is type 2 diabetes, and that's mainly what we're dealing with. Type 1s, we do see a few patients with insulin resistance. For the most part, they're on physiologic replacement, and where you really get into problems is the truly insulin-resistant diabetic patients that exhaust their beta cells and need very high doses of insulin. We're in a very different era now compared to when I started my career, because way back when we had first-generation sulfonylureas and animal-based insulin, and we've come a long ways because we have a number of medications now into different classes that don't cause hypoglycemia. So the way that we approach, at least at our clinic, the diabetic patient, and we're talking type 2, because type 1s, most of them are going to be on pumps, is that we really use, from very early get-go, combination therapy with medications, and we don't use any secretagogues. If people are on high doses of insulin, we try to reduce them dramatically or take them off completely. I mentioned it earlier. I don't like insulin as a molecule. I think it's a very bad molecule. It's atherogenic, and it can actually kill people, but you can't get away from it. We can't stop using it, but what we can do is minimize how much we use. So we try to use a lot of combination therapy, and for those that don't have the reserve, we'll go ahead and squirt them with some basal insulin, and we find very little prandial insulin is needed if you use the proper drugs in combination.
So that's a broader discussion of how we use various agents to maximize benefit and minimize harms. How do you look at hypoglycemia, Lisa?
So I'd say with respect to hypoglycemia that we've been focused on nocturnal hypoglycemia, but much more frequently in these patients on insulin, and especially basal bolus insulin, it's going to be during the day when they've miscalculated the the bolus dose around a meal, or missed carb counted, or things like that. So in a way, nocturnal hypoglycemia is much easier to deal with because you just decrease the basal amount of insulin for the patient. And that's often our strategy. And where we get into more problems is with patients doing too much of the rapid-acting analogs and misjudging either activity during the day, how much they're going to eat, how much they did eat, how many carbs were in it, or not checking their sugar before giving that bolus dose. So I think clinically the nocturnal hypoglycemia is a little bit easier to deal with, and we would just reduce the dose. There are some patients where perhaps that's an ongoing problem and you just can't get it right, and I suppose that's when this might be useful to switch drugs. But nocturnal is actually easier to deal with than the other.
Kim.
To what extent do you think this day-night dosing matters?
Yeah, so we haven't really discussed that much, this different time of day dosing. And this is related to this. This is one thing I would like to say. I would just thank ICER and CTAF for doing this sort of analysis, because I think as clinicians, we're inundated with hype around any new drug. Like, I have a stack this high because I'm keeping track of Toujeo handouts because they're trying to push that drug. And the physiology and the concepts, for example, the pharmacokinetics are such that you can dose this drug anytime, are really enticing. We're all scientists. We love the neat new mechanism of action. We love the neat physiology. But when push comes to shove, it's really, what do the clinical outcomes show? And in some things like cancer drugs, the clinical outcomes match the cool new mechanism of action. But unfortunately, in a lot of the diabetes drugs, that doesn't pan out. Avandia is a prime example where we look at vascular smooth wall, we're going to all have heart attack reductions, and yet it increased cardiovascular outcomes. So to your question, I view this multiple day dose or different time of day dosing as like that. It's a cool concept, but we don't really have a lot of hard data. And so the only data shows, we didn't discuss this at all, but it's non-inferiority, where you can dose at different times of the day, and it's not different than dosing Lantus at the same time every day. But of course, they didn't compare it to dosing Lantus at different times of the day. So it makes sense, but in real world terms, how much of an impact is that going to be? I don't know. Do I want to encourage my patients to take insulin whenever they think of it? Not really, because in clinical practice, the best thing is if you have a set routine. So until someone does the real world trial of saying, take it whenever you want versus take it the same time every day and looking at those outcomes, I've got to be skeptical and really focus on the data, which, like I said, is why I love this review, because it really summarized the data. I made everyone in my diabetes program read it after I read it.
Yeah. You brought up flexibility. I think that's a major advantage. I think Novo Nordisk was very clever. I mean, they used different size carbons on the insulin molecule. The shorter dissolved too quickly. The 18 carbon was too slow. And by coincidence, it just came out perfect that the half-life, in my opinion, is 24 hours. Because that really eliminates a lot of major issues. The studies have shown that most individuals that are on insulin intentionally miss doses here and there, either by accident, but a lot of them intentionally. What this 24-hour half-life allows is, first of all, no stacking, and so it allows you the flexibility that if you forget your insulin dose this morning, you can take the insulin dose when you remember this afternoon. And as long as the insulin doses are given 8 hours apart, you can return to your regular regimen the next day. So,
well, we're fortunate to have a chemist in addition to an endocrinologist on the panel, so you can comment on the chemistry if you wish.
Well, no, like I said, the mechanism of action is neat, how they got it to last so long. And that's really exciting, but and I think of all these, Detamir has the coolest mechanism of action. We won't talk about that or how it works, but Detamir didn't last long enough. And even though this lasts longer, what's the hard data on outcomes for that versus the concept?
So let me ask our panelists to ask their questions and also ask them to reflect on the difficulties they might have had in treating and helping to manage diabetes with their patients over time, because that's relevant here. So Marge and then Bob.
I have a question for Dr. Van Goor, and I hope this isn't an unfair question, but I'm always interested in how this goes to coverage issues. Yeah. So you said that you got very few requests, 130 requests for the drug. Without revealing any trade secrets, can you tell me, did Blue Shield approve of those requests? What did you ask of them to justify why they wanted to use this drug? What actually transpired?
I actually didn't pursue to that extent what our approval rate for that agent was, and I don't have that data. All I know, though, is that we did have a very, very limited number of requests for this agent.
So you don't know whether, in fact...
We don't know what the approval rate was. I don't offhand. We can research it, certainly.
Good question, Marge. So
Doctors Quinones and Murphy, fascinating statement. Patients intentionally miss doses. Why?
You know, I don't think I've ever finished a 10-day course of antibiotics. You know, there's a lot of different reasons, right? I mean, you want to go to the movies tonight, and you don't want to hassle it, taking it and so forth. So, you know, insulin, I'm type 2 diabetic. I praise God I'm controlled on an injectable that's not insulin and some oral agents. But I think if I had to take insulin, I would really be kind of terrified.
I mean, is it a quality of life issue or a cost issue? I'm still perplexed.
Well, you know, having one episode of hypoglycemia can really affect your attitude about insulin. A lot of times, yes, it is a thing of just your overall lifestyle.
I think also there's few chronic diseases that are so apparent and part of you every single moment of the day, right? If you have hypertension or CHF, you take your medicines, maybe you'll watch your salt a little bit, but really with diabetes, every single time you eat, it's just, and I think some people are just like, I don't want to deal with it, you know? And I've even seen that, you know, at my kids' chorus camp when I was helping the second grader who's like, I'm going to take an insulin holiday. I'm not going to check my sugar now. Like, I'm done with it. But she did it. But it's just, sometimes people just want to break from it. And I think that's part of the reason. And there are also other reasons. Can I just mention one great use of this drug that hasn't come up yet? And especially with the health plan people here. We see, and it is a percentage of the population with diabetes, this isn't huge, but as the percentage of the hospitalized population, it's a very large number of patients, and that's the completely non-adherent patient. And I work at a county hospital, so we have a lot of those patients who have substance abuse, mental health issues, homelessness, and your goal is to keep them out of the hospital rather than tight control. And a preparation that has such a long half-life is wonderful in those patients, right? If they take it 3 times a week, that could be the difference between being hospitalized and not, especially if they're type 1. So I guess the question for the healthcare people is, how do we have an easy approval process for those patients?
Let's ask Neil to discuss that first, and then Tony.
I mean, I think that's this conversation demonstrates why it's good to have a clinical and a policy and a scientific interplay, and kind of in the big picture discussion, it was pretty clear, almost unanimous on questioning certain values. But then when you get into special cases, this was a great special case. And this is the kind of thing that what we do take back in Medi-Cal, my role as medical director, is to come back when I report back to the meeting saying, and talk to the pharmacy group who briefed me on kind of reviewing the policies, to say, here's what at least on the fee-for-service side, which we directly control, here's something to keep in mind on the review. We certainly did that with hepatitis C in developing a policy and having these discussions of when might there be a very good use case for a particular patient, and this is a great example. So this is the kind of thing that when I report back to the medical directors meet quarterly, I can share what the formal reports are and the discussion. So I appreciate that, and that is how we kind of get the nuances on utilization review controls is this kind of discussion. So that typically doesn't come out in a systematic review. So it's good to have clinicians talk about special cases.
Tony?
I would certainly echo and confirm what Neil said about certain beneficiary groups and compliance as far as that's concerned, that there may be certain applications of an agent like this to patients that may or may not be compliant, but I guess a number of questions arise. If they don't take it one day, what says they're going to take it the next, and what says they're going to take it in such a way that it's effective? Difficult to say. I will say that in terms of our deliberative process right now, we would look for that with the claims that we receive and try to make a determination on that basis. But again, points out a very, very interesting issue that we'll consider.
Yes. Lisa, perhaps you can seek funding for such a trial while you're here. So from the point of view, we heard that the particular vulnerable subpopulations are particularly susceptible to diabetes, and we know that the prevalence differs between racial groups and ethnic groups and socioeconomic groups. So is there a consideration from that point of view as to these agents?
Well, along those lines, I was just curious, for those who are treating, do you have a sense of the willingness to pay, say, in terms of by patients for something like this, in terms of, say, increased copays or something like that? Are there patients coming to you saying, listen, if anything, I could just get rid of hypoglycemia, I'll pay an extra, it's definitely worth my while for some amount of money. I mean, because clearly, that's the case for the type 1s, because they often have to pay part of their pump cost and other things like that. But for these patients, are patients asking for this?
That's a question I really don't know the answer to, but what I will say is, one very, very mine-laden area that I really don't venture into very often in terms of my role with Blue Shield is cost and copays, although I realize that's important, obviously. The comparison, at least what we know with the WACs between this particular agent and other competitors is about the same. As far as how many are requesting it based on what they've heard about hypoglycemia, I don't have that information.
Let me just ask Marge, do you have any insight into whether patients are willing to see greater copays?
No, I don't. I would be surprised, based on what I do know about when people say they're willing to pay more. I think in this case it'd be a really narrow band of folks who would look at the data and say, yes, it's worth it to me to increase my copay for the chances of reducing the hypoglycemia. I'd be very surprised. Instead, they would be arguing why their health plan isn't paying for a perfectly effective drug.
Right, and then we can ask Tony again. All right, then Kim and then Rena.
I just want to piggyback on Dr. Murphy's point about different populations. An understudied population frequently in drug trials is the pregnant population. And I would like to put in a plea for some trials there, only because frequently they're non-compliant, especially if they work. Being able to test and eat and take their medicine is really difficult. And so that's a frequent reason for non-compliance in that population.
Gestational diabetes, any thoughts?
I don't deal with this population, and I really have very little in the past. And it seems like maybe even a more appropriate question for the pharmaceutical companies that design these studies.
Yeah, I think that's a good point. I think obstetricians are generally very cautious, and so I don't know if there's any safety data in pregnancy.
Cautious because there's more data.
Yeah. I will say, though, that in general, patients with gestational diabetes are at least far more motivated because of the baby than they are before or after the pregnancy. And so we see them a lot after, and we're trying to focus on keep doing what you were doing before, and that's hard.
I'll piggyback on that. I was at USC for many years, and it's almost like we had two different type of populations there. It was all indigent, but if you went to the general hospital, everybody was out of whack. And if you went down to Women's Hospital in the gestational diabetes clinic, everybody was tightly controlled. Same population, same genetics, just different motivations.
If it helps to mention this, I know that the agent is considered class or category C, as I recall. Okay. Yeah.
So just as a matter of fact, any additional information for us to consider? No. So in discussions on clinical trials for this special population, gestational. Rena.
Just to add to the comment about patient willingness to pay, in the real world, patients are really dealing with far more rudimentary payment issues, like just getting their testing equipment covered. In primary care, what we have to do to get patients enough test strips to test more than once a day, and the justifications that we have to do repeatedly to simply get test strips.
Give us some insight. Color commentary, what do you have to do?
Multiple forms, and sometimes multiple times per year per patient, justifying why does that patient need to test even sometimes more than one time a day. And if you have an uncontrolled, insulin-dependent diabetic who might need to test 3 or 4 times a day, we often cannot get that, just the test strips covered. So we're so far from patients being, willing to pay extra copays for a new insulin with questionable benefit when they can't get their test strips.
But I think that's in general with all of the classes of drugs that are still on patent that won't be generic for years. Even Byetta, that's 11 years old, that still has several years of patent that's left. But I think that's for all of us, whether you're at an academic center, whether you're out in a very high affluent area, or whether you're practicing in a Hispanic community like I do, where the great majority of patients are Medicaid. We call it CalOptima down there. That's the whole secret of getting your diabetics at goal, is that you have to face the fact that you are going to have to sit down and write on a piece of paper and send it back to the insurance company if you want them to get what you need for them to have.
Let me just get a little geographic equity here. Is it like that in Sacramento? Do you hear about this from your clinician colleagues?
In terms of paying for test strips?
Yeah, and the hassles of the
I'd say
basics.
for patients on Medicare, it's a nightmare.
On Medicare?
On Medicare, yes. Medicare is a disaster when it comes to glucose testing. For my other patients, not much.
I just curious, for people who are actually clinicians, how many of you have had patients have periods of not testing because they didn't have strips? And these are patients on insulin, correct? So,
right.
I mean, you talk about
vote
big
shell
barriers.
majority. Right.
Yeah.
So, Rita, you're our person in Washington in policy circles, power circles. We've heard comments about the FDA, Medi-Cal coverage policies, and now Medicare. How are those agencies looking at these chronic illnesses and asking for the appropriate coverage policies and trials to better address disease? I'm giving you an open-ended question.
Yeah. So how are FDA
Yeah,
looking
what
at
is your observation of how they're approaching this and how they could improve?
First of all, I can't speak for the federal agencies, but I mean, there's certainly a lot of interest in addressing illnesses of chronic disease, and in particular diabetes, because with an increasingly obese population, we're seeing increasingly more diabetes. So I guess for FDA, I mean, it's not clear to me, where that's going, particularly in terms of this discussion of testing strips. I mean, I think diabetes in particular has been, to me, very difficult and controversial because, as I think one of our experts noted, a lot of the drugs are approved on HbA1c, which is a surrogate outcome, not clear that it's associated with any clinical benefit at all. There's a lot of controversy over what the right HbA1c is. I mean, clinically, we know in the Medicare population, there are more now problems with hypoglycemia in older patients with diabetes than with hyperglycemia, and that suggests that, we've overtreated or went too far on the HbA1c guidelines. Certainly the ACCORD study, introduced a lot of questions about this idea that I had been, taught when I was in training, that you should be very, very aggressive and very intense on lowering glucose. So I think clinically it's very important, but and I think there's a lot of concern maybe with the sort of new trend in Medicare towards bundled payment and sort of more looking at outcomes that will drive trials that actually can give us more clinical information about outcomes and less on surrogate markers that I think for diabetes and for others is very hard to know what they mean and what to do with.
Critical points, the increasing number of elders who may or may not want to be treated to the same intensity as others, and this issue of whether we actually have hard outcomes, particularly for that elder population. Lisa has her hand up urgently, and then we'll come to Ralph.
Sorry, I just want to clarify a little bit. There are very clear outcome data on A1C and microvascular complications. That's not, that data is very clear. And I also think for cardiovascular outcome data, people often forget that the original tight control type 1 and original type control type 2 trial showed very large cardiovascular benefit. The difference in those populations compared to ACCORD and the later trials was all the type 2s were newly diagnosed. And for the DCCT, none of them had cardiovascular risk factors at the beginning. So very tight control early in the disease still is very important. And there's lots of data to show that there's microvascular and macrovascular benefit. Where it's not at all clear is in these patients who are older, who are further along in the disease. All these later trials that were specifically designed for cardiovascular disease were patients who had diabetes on average for 10 years. And so kind of the horse is already out of the barn. But we forget that in newly diagnosed patients and in type 1s early in the disease, the cardiovascular benefit was quite large, on the order of statins.
So metabolic karma we can think about, perhaps.
Yeah, so yeah.
Ralph.
I want to build on Rita's comment in terms of your query about how the FDA could do better. You know, it's interesting, their charge, as you know, from Congress is to show whether things are safe and effective. And so a huge void in terms of what we really need in terms of cost effectiveness is filled very nicely here by the ICER and CTAF initiatives. So one could argue that they could maybe branch out a little bit in terms of that. And I think Rita very wisely talked about the issue of using surrogate markers rather than outcomes markers. And the whole Avandia story would be a very different story if they had focused on outcomes. And I think the FDA is getting that after they do such studies or do approvals, that the idea of post-approval studies, and particularly registry, data collection, if they had done a lot of data collection related to Avandia afterwards, we would have had true answers of its safety and effectiveness, when in the present environment, 10 years later, we didn't really know. So I think the FDA is getting this, post-approval studies, drugs and devices in registries, so you can look at long-term efficacy, will make it a stronger institution.
Thank you. Other thoughts or comments? Paul and then Chris.
Yeah, along those lines, I think it's promising. Oh, you can see maybe what other people think who know Rob Califf, who should be the next FDA commissioner, coming from a cardiology trial background. And I know in the past, he has stated that FDA should be doing outcome studies and especially for diabetes, and let's stop with these intermediate outcomes. Now, whether that translates into a change waits to be seen, and I'm not sure if Rita or Ralph thinks that'll come to pass. But
you know, outcome trials, it's the ultimate. But I think that, how do I present this in a nice way? Cardiologists deal with patients who have already developed events and have active disease. I think that as endocrinologists, what we're trying to accomplish is to try to prevent these patients from having to get to cardiology. And so outcomes are good, but there's a pre-diabetic state that goes on for years.
A thought on that?
Well, I agree that it comes down to power and ability to show important outcomes for patients, and at some point it's just too expensive and takes too long to show that. But I think given the high risk that many of the diabetic patients do have, I think we still should look at that hard to see if we can get some patient relevant outcomes for FDA approval.
Chris.
So as was mentioned a little while ago, diabetes is a minute by minute, all your life illness to manage. And we can quibble, if you will, about which insulin is better. But really the big drivers of cardiovascular risk is the patient on a statin? And you can see someone changing from one new drug to another to manage their glucose, and there's no statin on board, there's no aspirin on board. Likewise, what about depression? My favorite diabetes med, I used to joke, was Prozac. That is a huge issue in managing this population. And then there's all of the time and energy that it really takes to be there for the patient and connect with the patient around managing their disease. And it's very easy to scribble off yet another prescription and set them off into their life. But is someone in your office contacting them on a regular basis, like Dr. Quinonez's patients are followed up on by his staff? And I think that those types of things are really make the difference in supporting the patient to do what they have to do to manage the disease. And another new expensive drug is not really the answer.
So we've heard about broadening the treatment beyond injectable insulins to other injectable and oral agents, and now the more holistic treatment looking at the variety of risk factors that contribute to the adverse outcomes. I'll come to Neil in a second. I mean, do we know for sure that all of our patients on insulin are getting broad risk factor modification? Have you looked at that?
I think there's a lot of systems like Kaiser and at the VA that do a very good job of that. I think one of the reasons in these, the Accord and Advance and these other the VA diabetes trial, which we're looking at cardiovascular risk reduction, they were underpowered in the end because we'd done such a much better job of taking care of these other risk factors than when they originally designed the trial. So we're getting a lot better at it. We're still not there.
Well, and we should say health plans are playing their part too. Do you want to comment on how you try to provide clinical cues?
I would say stay tuned for the next ICER meeting when we talk about the diabetes prevention program. Seriously, we're looking at this very, very closely with respect to modification of risk factors. We're taking very, very seriously the model that was given us with respect to the various factors that go into the development of diabetes. And we're trying to create a program right now modeled after the CDC program to help address this. Probably not germane to this discussion. Probably the next one is more appropriate.
Thank you. Neil had his hand up, and then we'll come back to Ralph.
I think this broadening of the discussion, and I like the focus on outcomes, which is how do people with diabetes, how are they doing overall? Our clinician colleague from UCSF said, can't even get the diabetes test strips. An article from Dean Schillinger and a co-author from UCSF said his patients can't get food. We have a third of the population in Medi-Cal, and so in the broad context of managing diabetes, besides the nuances between two drugs, just the basic testing, the food, and as we just mentioned, the prevalence of prediabetes plus diabetes in youth and children from the CDC is very high, 25% in youth and even higher in adults. So in our context, there's really a broader interest in them bringing in mental health, drug use, other factors, which are not just unique to Medi-Cal, of course. They are higher prevalence. We really have to think of those pieces and not just the physiologic side effects in terms of drug interactions, but this broader social fabric of getting people to come back and having food just to, basic management of their health.
Building on the comment on risk factor modification, the bottom line also is if you don't measure it, you can't manage it. And so the NCDR actually has started an ambulatory registry in collaboration with Joslin Diabetes Center and also the American Diabetes Association called the Diabetes Collaborative Registry, which is looking at all these particular aspects and can agnostically harness data from the electronic record and feed it back to clinicians to try to improve overall diabetes care.
So in addition to that registry effort, of course, we know that plans that seek NCQA certification have to measure and report such stuff. Patient-centered medical homes have systems in place to do this. The VA health plans are monitoring these kinds of issues as well. So do you think we'll be able to cover the tens of millions of diabetics and ensure their quality of care?
I'll let some of the diabetologists answer that question.
Has the treatment of diabetes improved over the past 15 years?
Yes.
I
hope so. I apologize. What was the question?
We'll assume you say yes, too. Has the treatment of diabetes improved over the past 15 years?
Absolutely.
And, you know, we're finally seeing that in terms of, I mean, it still is the leading cause of end-stage renal disease and blindness and non-traumatic amputations, but the CDC just recently released some new data that's showing it's leveled off and finally starting to go down. So I do think, and that's partly glucose control, but that's also, you know, lipid control and things like that as well. So I do think it is improving. And so that's why I get a little nervous about people wanting to back off too much with tight control, especially early in the disease, because I think we're seeing the benefits of that if you look at those other trials.
And that is good news.
Yes.
Yeah. Just one more comment. There was a time in life where if you had a diabetic patient, you had the luxury of sending them off to endocrinology. With the epidemic, I think the latest number is 52% of the American public is either diabetic or pre-diabetic. Endocrinologists are overwhelmed, and it's really going to take a lot of good education to our primary care physicians that everybody is in the trenches now.
And I think they do a good job in general. I mean,
Well, we can look to some of our primary care physicians and see how that's playing out. How many of your patients do you refer to endocrinology for assistance in management with diabetes?
Generally, only patients who are on a pump.
Yeah, I'd agree with that, but it's not the physicians, it's the care team, which we're going to hear about. So let's acknowledge that the physician is probably a minor player in all this. It's certainly the patient at the center, but then it's the care team, usually the diabetes educators and the nutritionists, the mental health therapists who are involved, as well as a community that can encourage the lifestyle changes. So we're, you know, just like in most areas of health, physicians are only a more modest part than we like to admit in terms of promoting.
Yeah, I'll second that. And we've actually had a behavioral health person in our clinic because we have such a high rate of behavioral health issues. And so they're there. They can't say, oh, I'll go and not go.
Any other thoughts, questions from our panel? Well, I think it's befitting a broad-ranging roundtable discussion. We've gone from chemical modification of a molecule to holistic considerations of diabetic teen treatment and public health implications. And with that, I'd like to thank our roundtable participants, our clinical experts, for their contributions today. Thank you very much. And we'll thank our evidence presenters, Jeff and Rick. Thank you very much. And now we go on to the section of our agenda where we ask our CTAF panelists for their reflections on the evidence, discussion, issues, analysis, and broader implications that occurred to them during the course of the day. And we like to encourage everybody to have something to say, so we usually start, Ralph, at the end of a table and ask for your reflections. And even more so, this is your first formal CTAF panelist meeting. So your reflections, please.
Well, my reflections of my opening meeting is I'm just thrilled to be here and honored that I can be with the august people around the table. I've learned a lot about diabetes and a lot of the, again, sage comments, particularly related to the weakness of the data that we were presented today about the, this particular new agent.
Michael?
I think I made my statement. I think, you know, ultimately the difference between this and the FDA's bars, this is ultimately going to get us to a way of measuring value, and not some subtle change or some subtle surrogate that's being measured in some trial. So, and I think we did that today. I think we had that discussion, and possibly the next one about diabetes prevention will show even a lot more value.
Joy, also your first time participating. Thank you for your questions already.
Yeah, I really appreciate the process and the sort of interesting twists on this process relative to other groups that I've been involved with in the past, so I enjoy it a lot. I do also confess to frustration with the quality of the evidence. I mean, it just seems sad to me that there would be, 8 RCTs, none of them were double-blinded. You know, none of them really could answer together, collectively or separately, the questions that needed to be answered. And that just seems very sad to me that we're still waiting for the definitive answers. We should have them already.
reflections for this morning's discussion, Meg?
Well, I'd echo what was just said. I also, as always, really appreciate the view of our consumer advocates on the panel. I think that the pungent comments made are refreshing.
At the risk of too much information, I guess I wanted to mention, since I was the one that thought there was adequate evidence for type 2 based on the hypoglycemia numbers. I grew up with a father with type 1 diabetes. I mean, literally grew up with him testing our urine about once a month. Everybody got their urine tested. We saw him give animal-based insulin to himself. This is all during the 50s and 60s. And we saw him have a hypoglycemic reaction. And he went into convulsions. And my stepmother knew what to do, and as we all did, actually. But it certainly had an impact on me. I grew up believing that diabetes was normal. I mean, that you could live perfectly, as he did, a perfectly normal life with type 1 diabetes. But you know, it kind of defined who he was in many ways. And so this was a particularly fascinating panel today. And I agree with the frustration that, given how long this disease has been with us, why we can't do a better job at the research to really help figure out what will work best for patients. It's sad, and I feel like we're wasting a lot of time and a lot of money, and I don't know what we can do to change the rules over how studies are conducted.
Thank you. Of course, we always have our chair make the last comments. So, Rita?
Thanks. I think I said a lot of my comments earlier. I certainly thank Jeff and Rick and Dan, the whole team, for really informing our discussion, because what I really, and the experts, appreciate about our discussions is that I think we do talk about, you know, the evidence and what's really important to patients, and that including, you know, the value proposition. But I think before you can have value, you have to have clinical benefit, and that's why I think it's so important that we're actually looking at studies that allow us to make, because to talk about prices when we haven't shown clinical benefit, to me, doesn't make a lot of sense. So I just appreciate ICER for the important role, and I think these analyses play.
Thanks, Lawanda. You've evolved from roundtable participant to panelist. Your reflections on the discussion?
So this was actually really fascinating. So thank you all for inviting me to be a part of this. The discussion, I felt is some tensions within myself, because I definitely agree with the experts that hypoglycemia is probably a bad thing, and repeated episodes of hypoglycemia are probably a bad thing for patients. But that's a leap that I'm making, because I actually don't have the data in front of me, and I couldn't find the data to say how bad is it and in what way. And I think that's the part that's missing in terms of being able to give a value to avoidance of these episodes that can help us to contextualize it against other treatments.
Thank you. And we're going to be asking our panelists. We've already thanked our roundtable participants. Rena, also your first time as a panelist.
Right. Well, I just echo what has been said about appreciating, you know, the opportunity to be part of this. I think the rigor that it goes into these reviews is just amazing. And I just want to mention, kind of along the same lines that you just said, that, you know, we really strictly interpret the question. The question is the evidence adequate? That doesn't mean that we don't think that that getting an answer to the question is important, right? I mean, it might be very important to answer the question about the differences in hypoglycemia and the effects of hypoglycemia, but we're strictly interpreting the question about whether the evidence that we see is adequate.
And I'll ask you, do you feel confidence and hope that it'll be easier for you to get your patients' test strips after today's meeting?
No.
We'll see what we can do in writing that up. Jeff?
So I thought this was an interesting discussion about, where the evidence is. This is kind of a Me Too drug. We have a drug that's long-lasting insulin, and what we're doing is we're looking at a drug that's sort of another one. And the way it was set up by the FDA is non-inferiority. So it just has to be as good as the existing thing. It doesn't have to be better. So we're awarding patent protection as a design for something that's no worse. My pet peeve, as you know, is MS drugs, and they only have to be better than placebo. They don't have to be better than existing drugs. And so we get all these drugs that come in they're never any cheaper. They're always more expensive. And so here we have patent protection to only be as good for something that's going to be more expensive. And is it any wonder that the studies are designed in a way that simply shows that they're no worse? That's what we're asking. And I think that the reason that the studies are coming in and you're saying, well, we don't have adequate evidence, is we didn't ask them to. And I think if the bar was it has to show superiority over existing drugs in some substantial way, I think you would have got a study that would have showed that the hypoglycemia in a real-world sense may be better. And I think it's just an interesting thing about thinking about generally what you do is you get outcomes that you ask for, and I think we're asking for a pretty low bar, and I think that might be where this is coming from. Not we, but, just society and the FDA and so on.
Thanks, Jeff. Alex?
We've mentioned a number of contextual factors in control of patients with diabetes, and I just want to make a quick plug for blood pressure. As somebody in geriatrics and palliative care, as I'm peeling back medications from patients, I'll first liberalize their hemoglobin A1C as decades of life expectancy turn to years, and then finally start to peel back blood pressure medications and statins.
Thank you.
Okay, once again, I have little hope of making this really cogent and seeming to make sense without running far afield left and right. Jeff and I clearly need to get together. We need to sit closer and work out our speech at this particular part of time. I want to preface this by pointing out, like I frequently do, I come from the cancer world, particularly with a lot of experience with cooperative groups. I know the value of head-to-head trials because I know that's the big deal about that whole little part of medicine. It's a really weird thing that doesn't operate like anybody outside of that club actually really thinks it does. It's not as clear-cut. It's nothing easy about it. The one thing that's clearly different about it is there's money to do the head-to-head trial. Deciding what you're going to do, how you're going to do it, that's a whole other little thing. But part of that process, once you get over that head, that came up in our preliminary meeting this morning. We'd love to have head-to-head trials. Everybody would. It's a lot easier to get the answer to your question. The problem with the cooperative groups and the head-to-head trials is designing the trials is actually not as easy as you'd think it'd be either. And getting everybody to actually go as deep into the details as they really should, to really get the pointy part of the question really out there, is not easy there. But back here, I'm going to come back to the single thing. We're not the FDA. The FDA has a different little bone to pick. Coming from the cancer world as a patient, I was there at the beginning. I know the fight for compassionate use. I know the idea that we need it now, no matter what the hell anybody says why I can't have it. I'm very sympathetic with that, and yet I'm very steadfastly against it. I know the downside. I know why we have the rules that we have. I know why we've got the structure of the system that we built up here. I'm very sympathetic to that. I'm not an apologist for the FDA, but I'll be damned if I'm going to let everybody run over them all the damn time, because we told them what rules they have to operate in. So let's get real about that. The one person I'm sorry I'm going to have to pick on here is our local man from Novo Nordisk. This wasn't designed the way it should have been. You didn't do the trial. I know you didn't do it, okay? So I'm not going to pick on you personally. And just for what it's worth, like I tell everybody frequently, I have yet to meet an evil person in the drug company. I have yet to meet an evil person on the insurance company. But I've met many of them in both of those regards that think their company does really bad things and they wish they had some way around it. This trial for this particular thing, these trials actually for this particular thing, weren't designed as pointy sticky as they should have been. right from the get-go. And I think this is just a poster child for the damn thing. As Jeff actually said, and he frequently gets it out before I did. To me, I actually see this as a terrible Me Too drug. I mean, it's like, why do I care? And the data isn't there to show me why I care. The data is there to show Manuel why he cares. The feeling of the professional on the treatment end of the world here. The feeling of it is there. The need for it is there. The usefulness of it is there. Maybe it's actually really worth it. It's not incredibly more expensive. It's not a no-brainer in that regard. But the one that's really got to change, frankly, is the drug companies, guys. You got to actually step up the game and go harder, faster at the answers that people like us want. And I guarantee you, I'd bring it up later. I'm hopefully going to get to it this summer after I write God knows how many little editorials about it. But the rest of the world is actually moving that way. NICE in Europe is actually, I've read a couple of things going on this week. They're heading in a direction that all of us clearly want to go. So it's not like we're not going to have to do it from everybody else.
I mean, you've laid out the issues very, very well, and you can discuss compassionate use with Jeff over lunch. Paul?
That just makes me think back to a patient in training who I looked through his paper record of 40 years to see that he was treated with depression with insulin-induced seizures, 20 series of those, that supposedly led to a significant improvement in his depression. And obviously we do know a little more about hypoglycemia, but as has been said before, I think what struck me about all of this is how much more we need to know about really what its impact is for patients in the long term.
You have a long memory. Thank you. Chris?
I work at a medical group that is sizable in Southern California, and roughly 10% of actually a little more than 10% of our patients have diabetes. There's a lot of people in the world, in this country, with diabetes, and to have studies with an N of 500 is an embarrassment. I think that we need to have studies, and we saw the same thing with hepatitis C. There's a great deal of money to be made for people who come up with something that's truly a breakthrough. So power the studies, show us enough people, and do it right, even if it costs you a little more to do it that way, because the patients, all of these patients, need to have effective treatments, and we can't tell if it's effective. That's a problem. Thank you.
Thanks. Rob?
As an oncologist, I really appreciated the review made up by the ICER staff. It taught me a lot. And I was just stunned as the discussion evolved to realize what a huge component of managing the disease, getting test strips and getting regular meals is. And we're talking about QALYs of 150 or 300,000, and you don't have test strips? It just seems very misplaced priorities to me.
We'll let that question hang. Kim?
It's hard to be last, or at least second to last. So I feel sorry for you, Chair.
Jen always has the last word.
I guess I wanted to say two things. And one, I like the idea of the once-a-day dosing. I don't want that to get lost. I think that is novel and something that can be beneficial. And to just sort of make that plea once again about the fact that half of gestational diabetics go on to become diabetic within 5 to 10 years. This is talk about getting somebody early in a disease and preventing adverse outcomes, and the whole philosophy of adult onset of, couldn't be worse timing, fetal onset of adult diseases. So we've got two people that we could impact if we could get them early.
Very good. And Mr. Chair.
Leaving your chair very little to say. There's been a lot of very good comments today, and so I must permit myself to give some historical perspective on this. CTAF, the old CTAF, used to look at devices and procedures because the FDA approval of drugs was so rigorous that we didn't feel we had to. It's disturbing to learn today that we've kind of gone wobbly, and Dr. Murphy points out that diabetes has gotten a special pass. So I think, you know, we didn't really get into the values so much because the data presented to us, it was like the old days of CTAF. And to see you know, surrogate endpoints, subjective endpoints in open studies. I was just so proud of this panel that we were so consistent and so unanimous in rejecting this kind of data. So I think our message is very clear that and it's been said before, that we demand better information if they want us to make some pronouncements about value. Thank you.
Our panel and 2 of our roundtable members are going to have to do this all again in just a short period of time. So I would ask you to renew, refresh, check your blood sugars carefully, and we will see you after lunch. Matt will give us the next set of logistics.